A very good morning and warm welcome to all for this national CLU, organized on the occasion of Centenary birth anniversary of our beloved founder chairman, late Dr. M.S. Ramaiah. I once again welcome all the delegates and your friends for this national CLU, Neuroanatomy from a Neurosurgeon's Eye, an integrated approach, organized by Department of Anatomy and Neurosurgery, Ramaiah Medical College and Hospitals. The brain is the crown jewel of creation. Neuroanatomy serves as the most fundamental body of knowledge, defining the beauty of this creation. Neuroanatomy has blossomed and holds an immense wealth of knowledge on structural brain anatomy and the integrated networks established between these structures. Today, we have the most competent neurosurgeons and anatomists who have agreed to integrate with us and help us to understand the complex anatomy of our brain and its clinical importance in a better way. The formal inauguration of the CLE will be at 10:20 a.m. and without much delay, we will begin our first talk. So I request Dr. Ashmi C.A., Associate Professor, Department of Anatomy, to introduce our first speaker, Dr. Pratap Kumar Ji. Good morning and welcome to all the delegates to the CLE on the Auditorium Junction. Dr. Pratap Kumar Ji, Assistant Professor of the Department of Anatomy, is the energetic and the youngest among all of us. In a lighter sense, our madam refers to him as the Krishna of our department, as is the only name. He's very much interested in imparting knowledge to the students and one of the favorites among the students. On the academic front, he has secured second rank in the PG exam under the Rajiv Gandhi University of Health Sciences and also the Best Postgraduate Award and Sir Arthur T. Gold Medal Award at the convocation ceremony of Ambedkar Medical College, where he pursued his postgraduate course. He also has been awarded the NBE Gold Medal in the specialty of anatomy for BA final examination by the Honorable President of India. He loves to attend quizzes and has won the first prize in various anatomy quiz competitions. He has around 20 publications in English journals and has also been awarded the best paper for oral presentation at the State Conference in 2016. We now call upon him to reinforce the knowledge on anatomy of the craniovertebral junction.
Morning to one and all. Audible. For the introduction. Yes, my topic is anatomy of the craniovertebral junction. So I will be doing this. Next. Bones, joints, ligaments, movements, muscles, skeletal structures, and also a bit of embryology. The craniovertebral junction, it is actually a common comprehensive term used for into the occiput first cervical vertebra and second cervical vertebra. And also supporting ligaments. It's a transition zone between the mobile cranium and the vertebral column. It encloses soft tissue such as the medulla oblongata, spinal cord, lower four cranial nerves, and the first three cervical nerves. So this is the occipital bone. The structure is closely related over here. The parts of the craniovertebral junction includes next one: occiput, the first cervical vertebra, second, and the articulation between them, and the connecting ligaments. You can see the bones here. We do these bones individually, like occipital bone, first cervical vertebra, second cervical vertebra. occipital bone. This is the bone which is present in the posterior aspect of the skull. So occipital refers to the back of the head. So this occipital bone is. So we have got the following parts. So this part is called the base of occipital. This part is called the coronal part. This part is called the smallest part. See this line. Front of coronal and side of and behind are the three parts of the occipital bone. So next vertebra is the first cervical vertebra is part is atlas. Atlas is the title of the chief part of mythology. Means the warrior was told to given us punishment to hold the heavens is shoulder. So similarly, we have the atlas first, so it is the globe of the skull. So that is the meaning of derivation of the word atlas, the first cervical vertebra. So this atlas is got the following parts is given. So anterior arch is short. Posterior arch is long and strong. It forms the two-feet of the circle and it has got a surface of the vertebral artery. There are two lateral muscles. You can see the articular facets of the lateral muscles. The one transverse process and we that the following in the transverse process called as following transverse area. So these are the various parts of the atlas. So here this is the axis across which the earth rotates. So the second cervical vertebra along the vertical axis passing through the odontoid process. The atlas, the entire skull will revolve similar to the globe. So that's the way the word axis comes from. So axis consists of following parts. It consists of a two-phase projection on the upper surface of the body called as odontoid process, or also called as the lens. This is a larger body. This is the articular facet. This is enclosed around the body. The cranium, the inferior vertebral arch is over there, and the short transverse process and the coronal transverse area is dilated laterally and slightly upwards. The two lamina to the broad and down are projected backwards, and the spinous process which is bifid. Same thing, somewhere here. The joints of the cranial vertebral junction, the first joint is between the atlas and the. So it's called as atlando-occipital joint. There are two joints on either side. So this is the lateral joint. It is formed between the inferior articular facet of the occipital cortex, which are convex and directed angular-laterally, and the superior articular facet of the first cervical vertebra of the atlas is angular-medial. So you can see the direction here. You can see this root and concave and here it's convex. So it is the form of so it will be formed here is next to the occipital joint is an ellipsoid type of synovial joint. So in this ellipsoid type of synovial joint, the movement takes place in a transverse axis. So transverse axis in such a way the skull will move forwards and backwards. That's the five movement. There are various ligaments attached to occipital joint. Summarized, the ligament includes this capsular ligament is attached to the margins forming the occipital condyle and the superior articular facet. This is the anterior attached occipital membrane between the anterior margin of the following macula and anterior margin of anterior occipital. This anterior occipital ligament is reinforcing that. So here you can see the posterior attached occipital membrane coming from the posterior margin of the following macula, posterior occipital. On the inferior aspect, there is a branch or the vertebral artery to travel into this. This is the movement you can see animation, but is the movement possible in the occipital joint. You can tell. So this axis, this is the axis, transverse axis in which both the attached occipital joints will be used and move forward. Cell will move forward across the atlas. So this is fraction of 3 yes. So the word is this point. There is a slight side to side movement also possible in this. The side to side movement is called as lateral flexion. This lateral flexion takes place around the anterior posterior axis traveling across the atlantis. Moving on to the next joint, it is atlanto-axial joint between the atlas. The The atlas didn't have the body that is torn by the axis actually. It's found a two-plane process called the rotational process. The atlas had only the anterior arms and the posterior arms. The atlantoaxial joint have two joints, one in center and one on either sides. The central joint is formed between the rotatory process of the axis and the anterior arms of the atlas and the transverse ligament of the atlas. So it's like a pivot or a central surrounded. Okay. So this pivot type of synovial joint is the median atlantoaxial joint. Whereas the inferior articular facet of atlas and the superior articular facet of axis forms the plane type of synovial joint. In the median atlantoaxial joint allows the pivot type of movement, that is a rotating movement. The plane type of synovial joint will allow gliding movement. So only when it glides, the movement is possible. From the ligaments rotate, first of all, the median atlantoaxial joint will have the dorsal and anterior plane and the transverse ligament of the atlas for the posterior plane. That is the ligament over there. The lateral atlantoaxial joint is the lateral. So you can see the capsular ligament here, the lateral capsular ligament of the lateral atlantoaxial joint. Anterior is anterior longitudinal ligament also reinforce the capsular ligament. So other ligaments which reinforce the atlantoaxial joint include the cruciate ligament. Actually, the cruciate ligament is formed as a transverse ligament of the atlas, and upper band of cruciate ligament goes to the base of the lower band will go to the inner surface of the body of axis. Also, there is an apical ligament and malar ligament of the pelvis. That is the median atlantoaxial joint. Neurosurgery membrane is called as the pectoral membrane. It is covering all these ligaments from the posterior aspect that has been reflected here. You can see the apical ligament here and the other ligament, which is stabilizing the pelvis or the rotatory process. So this is the same thing in the discussion. So this is a movement please observe. This is a movement possible. It's a rotating movement taking place around vertical axis. This vertical axis is passing to the rotatory process of axis. The axis is called as axis. Yeah. This is only a movement. You can see the atlantoaxial joint is used. Now, the movement is by atlanto-occipital joint. Which takes place in craniovertebral junctions. The muscles in the craniovertebral junction includes the posterior plane. We have the next to rectus capitis posterior minor. Next. Rectus capitis posterior major, superior obliquus capitis, inferior obliquus capitis. These muscles of the posterior aspect reinforce the craniovertebral junction from behind. They help in extension. These muscles help in extension of the present midline, and those muscles of the lateral cranial junction rotating movement. The muscles in the anterior plane include the rectus capitis anterior and the rectus capitis lateralis. Lateralis helps in side-to-side movement. Anterior helps in flexion of the vertical column. The neural structures involved in the craniovertebral junction you can see in the symbolic. This is the medulla oblongata. This is both ventricle, cerebellum, especially the tonsils and the frontal lobe. The spinal cord. The last four cranials, that is 9, 10, 11, 12. The first three cervical nerves are related to the craniovertebral junction. Next. You can see the blood vessels related to the craniovertebral junction, which includes the ICA or ventral neuroanatomy. The vertical artery passing through the foramen transverse area and reaching the cranial cavity and forming a circle of this is closely related to the craniovertebral junction. So, same thing is depicted in the line diagram here. The base related to the craniovertebral junction includes the visceral venous plexus, the base occiput, the internal vertical venous plexus, or the inside of the vertical column, the cervical vertical column. The suboccipital venous plexus connected to the external vein, the occipital sinus, which is there on the inner aspect of the occipital bone, the midline. Last but not least, I would like to summarize the embryology of the development of craniovertebral junction last 2 minutes. So the gastrification initial stage is where the three germ layers are defined as the ectoderm, endoderm, and mesoderm. This mesoderm is divided into 3 parts by the center of the axis of the embryo is called the paraxial mesoderm. Then in between the paraxial and lateral is called intermediate, and the one which is very close to the exterior is called the lateral drainage mesoderm. So we are interested today in this paraxial mesoderm. This paraxial mesoderm is the one which differentiates into tube-like structures called as somites. So it subsequently these domains differentiated into ventromedial portion called as scleroderm. It is the scleroderm portion which gives rise to the particular column. So here, consider this as the occipital somates. The occipital somates, which are the pre-cervical somates or the scleroderms, will be differentiated into the occipital bone. This is part of the craniovertebral junction. So these scleroderms, numbered 1 to 4, occipital scleroderms 1 to 4, they form the base occiput, which is nothing but the structure which is different to the foramen. The ex occiput, which is the side of the foramen, and to aspect supraoccipital, which is nothing but the squamous part of the occipital bone. So here I would like to re-emphasize that the scleroderms are divided into half, the cranial half and the caudal half. Yes. The caudal half of the superior sclerodome joins to the cranial half of the medial sclerodome to form the vertebral body of the center. Subsequently, the previous phase. Subsequently, a neural arch develops and it encloses the developing neural tube from behind, which leads to the Ramaiah of the vertebral column and the spinal process. So here, these are the occipital scleroderms and this is the proto-atlas. The fourth occipital sclerodome is called as proto-atlas. So here, I would like to re-emphasize here. This is the proto-atlas. This proto-atlas gives the following part. That is the base of the skull, only the anterior portion is there over here. The anterior portion of the foramen magnum, the apical portion of the lens, and this apical ligament and the alar ligament. So this portion is given as the proto-atlas. Whereas the first cervical sclerodome given as including this, including the lateral mass of atlas and the upper margin of the posterior of the atlas. Well, the first cervical sclerodome is given as the entire anterior half of the atlas, including the odontoid process and the posterior arch, except the superior margin of the posterior. That is derived from the first cervical sclerodome. The second and third subsequently given as the corresponding vertebra. It is the cranial half of each sclerodome which joins with the inferior sclerodome, joins with the lower half of the superior sclerodome, given as the corresponding vertebra. That is the summary of it over here. So this is the summary of it over here. It is the occipital sclerodome, base occipital, another point, and smallest point. Whereas each of these sclerodome divided cranial and caudal half is a cervical sclerodomes, given as the proto-atlas, upper portion, below portion given as the median portion of the atlas, is subsequently the same. So initially, what happens? The blood vessels which are going to the corresponding sclerodomes, there is the corresponding sclerodomes. Now the neurovascular blood vessels will be in between the sclerodomes, so it will become the intercostal nerves. Now they become intersegmental. So it is the intersegmental blood vessels. Next, please. So that's all my topic. Thank you for this opportunity.
Thank you, Dr. Pratap, for giving the interesting presentation. Now I request Dr. Prakash PS, Professor in Lecturer, National Institute of Medical Sciences, to hand your memento to Dr. Pratap Kumar. Pratap, you thank you. One book for this. Wait. Thank you, sir. Now I request Dr. Ashwini to give brief introduction to our second speaker, Dr. Nishit Reddy. Profession, is currently working as assistant professor in the Department of Neurosciences of Ramaiah Medical College. He's in charge of the residential teaching program, actively coordinating the daily teaching learning activities of the residents. In addition to patient care, he is also a member of the telemedicine consultation team. Currently, Dr. Nishit teaches himself updated by attending conferences and workshops. He has won many accolades for oral and poster presentations in various conferences. He has 7 publications in his various index journals to his credit. Now invite him on stage to deliver his talk on clinical importance of failure-vertebral junction.
Pointing the system point. Time also. System report.
Good morning, everyone. Respected teachers, colleagues, all the delegates, and my dear friends today. It's an honor to be given this opportunity by the Department of Anatomy to be able to do a discussion about it. Before I start, I'm a neurosurgeon, and also thank you, Dr. Ashwini, for that generous introduction. I'm not sure if you know about that. Let's start now. How many of you are anatomy students, undergrads here? Oh. How many are anatomy postgraduates? I'm sure we have a few neurosurgery. Right. So this talk is tailored to reflect on the applied aspects, okay, more the clinical aspects. I want to extremely elaborate and that we keep it concise and succinct to what you need to understand. So first of all, thank you, Dr. Pradhan, for the fantastic introduction and giving us the anatomy, the embryology of the CPA. So I will start with So I think repetition is good, right? So you just find this great talk by Dr. Pradhan. I'm going to repeat some of the movements over here because I feel while talking to you about the biomechanics and the CV motion. Right? So, in the overall motion of the cervical spine, the period junction it contributes up to 25% of the flexion extension and up to 50% of the axial rotation. Okay? So flexion extension 25%, 50% of the axial rotation. And like you mentioned, there are two distinct joints. They are the louder. Excellent. So the tongue also belongs to the joint and the tongue which is joint. Now P is a special they function as a single unit in a lot of movements. And the movements can be flexion, extension, it can be rotation, or compound movements combined. Okay. Generally, we tend to have slightly more angular motion, the CDJ, and this motion also decreases with age. So I will table that, which gives us the general degrees of motion. This is not at least 50% particular. Okay. Biomechanics. Biomechanics is basically mechanical loads which are put on the joints. Why they are performing very important. Why is this important? We have to understand physiologically what happens. Pathologically, what goes wrong. It's super important to know and understand biomechanics because whenever we do surgery, we have to fix the spine in a position which is biomechanically suitable. Otherwise, it ends up causing a restriction of movement or stress on all the other joints. Okay. So at the beginning of flexion and extension is about 24-25 degrees. And this is restricted or rather protected by contact between the odontoid process and the occipital. All of you remember the odontoid process is part of C1 or C2? Okay, good. Also known as length. And the extension Some studies say it may be limited by the pectoral membrane, others don't agree. But we know that the pectoral membrane plays a part in protecting spinal cord cavity bone. Rotation is a flow of resistance movement here. It's about 2.5 to 7.2%, and 3.5 to 5.5 are the lateral membrane. Both of these movements are guarded by the bony articulation points, tibialar ligaments, and capsular ligaments. So remember again, the primary movement of importance for us at the run-occipital joint here is flexion extension. Okay. Okay. So it was flexion extension there and the adductor C1, C2 joint. The primary function at this joint, on the other hand, is axial rotation. Now, if the cervical spine totally gives us an axial rotation of about 49 degrees, the C1, C2 joint itself constitutes 38%. In that movement, whenever we move side, the movement of the C1, C2, the AA joint is countered. Actually, there's an opposite movement. That's why I've written a negative 4 degrees at the AA joint. Right. And finally, the rest of the spine, we also know the subaxial spine from C2 to C7. That has 15 degrees of motion. The 38 minus 4 plus 15, that's about 49 degrees of motion. And the auditory plays the pivot over here. This is protected or limited again by the inner ligament, accessory adduction ligaments. Okay. Right. Of course, there are other movements as well. Flexion is 10 to 20 degrees, lateral bending is about 6.7 to 11. Okay. And these, but remember, flexion is guarded by the transverse ligament, the transverse part of the cruciate ligament. Extension by bony articulation one time, pectoral membrane. Lateral bending, alar ligaments, and the other capsular ligament. Right. Okay, primary movement at AO joint, what is it? Flexion and extension. Primary movement at the C1, C2 or AA joint. Great. Okay. So now everyone is they've kind of understood that these are the movements and what's the primary movement, right? So that's the biomechanics of the physiological spine. So pathologically speaking, there has to be something which can destabilize the biomechanics of the cervical the craniovertebral junction or the cervical spine itself. And those can include things like trauma, degenerative diseases like rheumatoid arthritis, neoplasms or tumors, infections, iatrogenic injuries. For example, when we perform a surgery, sometimes things are destabilized. You learn that if we go in from the anterior direction and remove part of the auditory process when it's fractured, we have to fuse behind as well. Because removing that disrupts the ligaments around it, and that causes instability. So that is iatrogenic. Iatrogenic is something that we use. And then there can be congenital defects, like Down, in syndromes like Down syndrome, Ortho syndrome. These are all cases where there is increased axial instability and chances of disability. Okay. Now, the instability that occurs with either dislocation or subluxation occurs because of two reasons. Due to bony fracture and due to ligament. Okay, or lax. Right. Let's deal with trauma. This is the most common thing that we as neurosurgeons, no, anybody in the clinical side sees in terms of cervical spinal injuries. Okay. Can anyone tell me one sort of event which causes cervical spinal injury or a CV junction injury? Angry, okay. Something common than that? Whiplash. Whiplash, okay. Somebody said whiplash. Okay. So, high energy motor vehicle collisions, you're driving at about 100 kilometers per hour, you go smashing into something because you're carrying all that inertia and suddenly it comes to the front part, you go swing back and the flash obviously. Okay. or it can be a fall from a certain height. Even a height of a meter or 5 stairs, okay, if you fall in the right angle or the right way, that causes enough axial loading on your spine and that can cause certain injury. Usually, the high speed collision and diving accidents. So again, I said, either the bony structures, any of the bony structures which you get, that's going to cause some of the ligaments. The important ligaments, anybody can guess what the important ligaments are? Or, we said, I discussed in biomechanics, restriction or limitation of certain movements. Okay, tell me. Transverse ligament, super. Okay, so you're going to hear a lot about transverse ligament and the alar ligament. Those are the two cardinal ligaments, okay, whether it's going to talk about limit flexion or limit rotation. These are super important. So even if you don't remember all the 8 ligaments, remember 2 or 3. Okay, and that's going to. Now, when this happens, when there is injury at the CVJ, what can get compressed? Basically, tension giving way to the spinal cord over there, and that can get compressed. So you can have limb weakness. You can have neck pain, severe spinal pain. There can be normal neck position. There can be restriction of movement. Can also be other things like if it goes further up, like the auditory goes up and presses on the brain cells. It can be hypoglossal, even after 6 nerve injury, syncope attacks, so many things. But you should understand that all these are symptoms that you see in case there is a CVJ injury, especially, and we most commonly see it segregated trauma. Okay, so investigations. What are you going to do? Okay. If the patient comes to casualty, first protocol, check you out, you're going to find these symptoms or signs. MRI. Okay, so we used to do an X-ray. Now, because we have the CTs, as we're doing a screening CT of the head, we also do a CT of the cervical spine. Okay, and because the CT is going to tell us about the bony disruption, the MRI is going to tell us about the soft tissue compression, which is basically the spinal cord and nerves. If there's any disc which is herniated, is there any ligament dysfunction or injury? That's what it's going to tell us. You can determine a lot by just an X-ray. All of you, anatomy, Chaurasya, applied anatomy over here, look for CV junction. What's the view called? X-ray view. It's there. That's an open mouth. What is the view? Okay. I remember that from Chaurasya. Anyway, so we do a CT of the C-spine and MRI of the C-spine. We also want to sometimes do CT angiogram because sometimes people have abnormal vascular anatomy because the word was not and then it basically transfers from there and enters into the liver goes up. So we have to be careful because if we should injure the liver, or there can be already some injuries following from an X-ray is fine. You always run AP and a lateral view. Do not flex and extend the patient and in a trauma state. Yeah, okay. So, any trauma causes 2 things primarily. Bony injury, ligamental injury, like I was saying. So, the fractures are what are we talking about? So, looking at the occiput. So, the occiput contents can be fractured and the C1 of the axis level. I'm only talking about something called the Jefferson fracture and the axis fracture. If you talk about orbital process fractures, the bar is also known as axis fracture and audio axis fracture. The ligaments again, transverse ligament, alar ligament, territorial membrane. Okay, flexion, rotation, extension, all these limiting membranes. So the ligament injuries can be tears or they can also cause with a piece of bone when they're inserted into the bone. Okay. You don't have to break your head too much, but try and understand. Okay. Type 1. So we're talking about occipital condyles. Okay. So if I take a connection, this is your occipital condyle. C1 and C2. That's your orthodontine process. Okay. This occipital condyle over here. A comminuted fracture is one in which it's the bone is shattered. Look here. This axial compression injury or axial loading injury, basically something's pressing down on that condyle, smashing it over here. So there's a load here. But none of the fragments are entering into permanent magnet. It is an impacted fracture. So it is relatively stable. The next one is a basal skull. Now, since I have skull base fracture, and you know the skull base extends and forms the permanent magnet. Okay, so if there's a linear skull fracture which is extending onto the condyles, that is a type 2 fracture. So condyle is shattered. Condyle is shattered, but it isn't stable. It's like one. Type 2 is when fracture extends, and type 3 is which is also unstable. This happens because the person is actually bending by the engineering of force. If the loading is happening in turn position, there's actually contralateral bending and rotation which is happening in addition. So, and it's pulled by the ligament. So that piece, that fracture going from it goes into the permanent magnet or it is unstable. Okay. Everybody to understand. Communication, linear fracture, basal skull extension, or it can be this. Next. We come to after the occipital, we come to C1, the atlas. Jefferson. Okay. In about 1919, Jefferson classified this, he described this particular fracture. What happens here is there's basically axial loading, and see, these atlas fractures can be only the anterior, only the posterior arch, and then they can extend on to the lateral. Jefferson fracture is when generally both happen, the anterior and the posterior arch. So imagine there's a break in anterior, we have about 4 different fractures, and that is a Jefferson fracture. Similarly, I can give an example of how this particular fracture will happen. Okay, fall from height. More commonly, I mean, we don't go every day and start falling from height. No, that's not what we do. So, think of diving. Okay, when you're diving and you dive upward, so there's an axial load on top. The condyles go smash and press into the processes of the C1, and then it splits apart, cracking the anterior and posterior. Okay, that is one event which will cause it. Okay, done the occipital. We have a very big discussion on C1. This is C2. C2 can have an odontoid fracture, it can have a harsh fracture or a bony fracture. Okay, for you to understand, the C1 has a lateral mass. That's basically the bone between the two cells. The bar, the bridge is between the lamina and has only the C2. The C2 is better than it has a pedigree. The C1 does not have a pedigree. C2 also has the body, and that continues upward and so you have 3 different fractures here. One from the odontoid, one from the heart, and the other is going to be the body itself. Okay. Simple. Okay, if you have your thumb here, think of that as the tip. You snap the tip off. Okay, just the tip. That's not going to cause much, problem to you. And that is the thing. Type 2 is where the thumb is attached to the rest of your hand. Okay, right at that junction. You will not be attached to C2. That is your type 2. And the most common and the most unstable. Type 3. Next slide, please. Next. Yeah, so the type 3 is basically where the fracture line extends through the body of C2. So, usually the type 2 is more than actually low. Type 3 is more than or here is actually a combination. There's both a lateral force as well as a force. So the force basically snaps it off, and the axial force stops the alar ligament, and that causes the breakage. Next, please. Okay. Everyone kind of has a mind of it, what is that process? The tip goes everyone. At the junction between the Auditorium process and the body, only the anatomy under it is unclear. Okay. Come on, all of you know this. Okay. And then there is a fracture. We're clear on that. So usually the Auditorium fracture sends go to the path. Okay. The paths interact articular structure. We know one of these fractures most commonly is the Hangman's. The Hangman's fracture is also known as traumatic spondylolisthesis. Listhesis is when one vertebra slides forward or backward, it slips on top of the other one. Okay, so there's a traumatic spondylolisthesis. Typically, hyperextension distraction. So, hanging, because they found that there was angle knot, there is a submental knot, which pulls the spine, like it pulls the neck backwards, the head backwards on the neck, and that causes hyperextension. And then there's the body which is hanging, so that causes a distraction and extension. Okay. Now, with the AO joint, actually, because it's more extensible, it's it doesn't really conform to this. Whereas the A joint cannot withstand this, and invariably the ligaments will snap and the bone breaks and comes down. Now, here's the thing: those the angle fracture, there are studies which have seen there. There's a study that is like 34 division angles. Only 6 of them had an axis fracture, and in that only 3 was a classic Jefferson fracture. So it might be, we know normally it's always after the Hangman's fracture, but even more commonly, it is seen in a motor vehicle collision because you're going you're driving, and suddenly if you have a head-on collision, your head, which is like that, goes snaps and hits either the steering wheel or the dashboard, and that causes the loading. You bring the extension and then you hit the load. So that causes this fracture. That's the most common etiology. Okay. Before I jump into this, we've seen fractures. Okay, there's also ligamental injuries. We won't be going too much into them, which is basically your transverse ligament, alar ligament, pectoral membrane, and so on. So fractures repeat. Okay. Auditorium type 1, 2, 3, tip, okay, and then the junction and body. Then you saw Hangman's fractures, and then there are a whole bunch of body fractures. That's C2. C1, you looked at what are the naming fractures? And Auditorium was a hospital corner 3 times. Newton. There was a base of skull, and there was one fracture with avulsion. Okay. So now, for us, what is also the axial joint? The aortic joint is also important, but these dislocations can be an aortic joint, the AA joint, and they can be something for baseline. Okay. Normally, we measure space between the anterior arch of the axis and the dent. Okay, that's called the AVI. Okay, the axis dent. So the normal is 3 millimeters corners and 5 millimeters. So whenever I receive this, that means there's some laxity, there's some instability. Okay? Yeah. So Dr. Pratap had this picture, this is the super important ligament over here. So if there's a traumatic disruption of the transverse ligament, obviously the distance between the anterior arch and the dent will increase. Very understood. Yeah. Then generally there can be laxity over here in Down syndrome, Walker syndrome. In rheumatoid arthritis, what happens is it basically these bones. Where is the insertion of these ligaments? Various ligaments, not just that, and that causes the instability. Okay, again, next. Apart from the anterior posture, there can be rotatory instability as well. That's something you need to know. So again, X-ray we should get here because it's not traumatic always. We can get a X-ray. Same other thing, other investigations. Now, I won't go into radiography, but this is a whole topic, okay? And like an essay question where you need to understand that we draw these various lines between the base of the skull, the cervical vertebrae, we measure these angles. This is like called Wagner's line between, back of the position and stylus. If it's less than 120 long, 150, 180, we know that there is plateau or plateau of the skull that happens with more association with this kind of relation. So there's a number of indices that you really have no idea. Okay. But you understand that we make all these measurements, we should make it on the screen, now we make it on the CTs, it's far easier. And that kind of tells us, yes, there's instability. Why do we have to know if there's instability or not? Because we don't know whether we just this is fine or also go ahead and put screws and fuse it. Next, please. And just like there's a triangle axis, there can be also a triangle occipital. This patient with this really has a higher mortality. It's a much more high speed velocity injury. I won't deal with this right now. Next, please. Yeah, so this was one of our cases. Dr. Rajan was performed this surgery where, see, we measured, it's not very clear, but there's a green line there. There's a green line there. So that input was measured and it showed there was instability. And we ended up using this patient. This patient actually with Atlanta Hospital, the dislocation, she was presented with syncopal attacks. And we found when we did the CT and the MRI that there was an injury. Down syndrome. Most of you heard of it. It's most common chromosomal disorder, trisomy 21, when every 700. So, with it, apart from the molar eyes, the slant, the long blue hair, and all those other things, we also have a very high chance of neurosurgical instability. Majority of these cases are missing. When it becomes important is, when these people have trivial injury, people who have instability, when you go to your barber shop, these facts, we find those people who come to our OPD and they can't move, and or they have some deficit after that. With Down syndrome patients, the anesthetists have to be exceptionally careful because there is that increase in and when they're intubating the patient, the highlights come next, so we have to do microoptic intubation. Okay. So one theory is that there's an aortic instability because the hospital layers and the C1 superior articular processes are flatter. And as the time goes, basically they become round, and that causes a normal bone formation. So when the corners become rounder, they kind of move around more. The other is ligament instability. But in general, the instability is a combination of factors. Which includes also that's where everyone is from it's disparate from the body. And then there's like beginning vaccine that can be change. In rheumatoid arthritis, what happens is erosion of bony component of the great and here there are immediate changes which affect insertions of various different transfers in the immune system. And it's seen in about 20 to 86% of the patients. And further disruption happens to the called and the auditory process. And these patients can what is called as basilar inflammation. That's basically when there's a translation of vertical translation of auditory process. And with subluxation and dislocation of the acoustic. They can be pancreas is but a normal formation within the joint. And this can further compress the body. So like I mentioned, this is baseline imagination. You see the kind of the line going up, it's compressing on the brainstem. So this is seen clipper file, TRE malformation. I mean, there are various associations, and it's commonly associated with AD, rheumatoid arthritis, Williams disease, all this. So we can have a very, very simple list from headache, restricted neck movements, cranial nerve deficits, and so on. So we have to correct that. That part of the rheumatoid is pressing on the has to be exercised. You put it on traction, pull it down, or exercise it. And here what you can see is a transfer between both through the mouth. Motion pattern will wall is opened up, and then you're actually exercising the auditory process there. But then it becomes unstable. So we turn the patient, flip the wall, and screws in the back and feel sort of clean. And those are all those lines that I was talking about. Okay. everybody is kind of understood it now, right? There is fractures, ligamental issues, and ultimately they cause instability. That's the problem here. Deficit and instability, or instability in mechanical data. So we have studied the physiological, biomechanics, we looked at pathologically what happens, and now it's important to follow that through even when we operate on these patients. Okay, so it becomes so at different points we can use the oxygen, the atlas, the axis. So actually, this is where we make small blood holes over here, and then do a construct with wiring. It's not really done. There's an occipital plate which comes. These occipital screws actually are very cervical screws. There are a lot more blood than thicker, they have smaller page. And the keel, the keel is right. So in the ship's power, so the occipital also has a keel, and that's the biggest part of the bone. So the pull-out strength of the screw is maximum at the keel. So that's the design. So these plates are designed like that. And then we put screws in the cervical vertebra. We have to have a vertical construct because if we fuse this stop the joint movement, but we also have to have rotational movement, which has to be lost. And so we try to fuse the patient's, like in very physiological position. You can't fuse the patient looking like that. Now, why do we need a blood clip, by the way? Actually, this is common sense. The brain unit. It's more than that, it's a neuroanatomy thing. It's a constant neuroanatomy. We don't put that in screws and now, the C1 screws or the lateral mass screws, I'll show you a picture. And then there's something called sublaminar wiring and laminar hooks, which is an older technique. These screws are generally longer. By bicortical, every hook has a cortex, two cortices, outside and inside, for inside and inside. We look for bicortical purchases in both of these screws are long. And then there's something called a golden cortex screw, which is called a lag screw. The more you tighten it, the more that's true. In C2 level, unicortical purchase is not. Actually, you can see we won't try too much more bicortical purchase. Here, there's the number of parts, the side.
These slides.
Ultimately, when you have anchor point with the oxygen, C1 and C2, you have to fuse them together. So there's an oxygen cervical fusion or fusion, and there's a C1 C2. Yes, these two have or we can use one single screw needle for the transaction. Next slide. So this C1 has lateral mass or pedicle. This is a pedicle screw. This is a bucket screw. And this is a transluminal screw. This is the so ultimately, see that these are post-op X-rays. So the oxygen is like fusion there. You can see that the screw is just coming inside the bone, the bicortical purchase. Even though we are just inside at the C1 level, but not in the C2. So here that's the lateral mass screw, the bar screw, just inside. And finally, can you see these? These are those laminar screws. This is how we use it and preserve whatever carries. Thank you very much. Any questions?
Thank you, Dr. Nishish, for the wonderful presentation. Now I request Dr. N.S. Sivakumar, former professor and head Jifar Puducherry, former dean Jifar Karaikal, and presently working as a professor PGSN on Medical College, to hand over the momentum to Dr. Nishish. Stage center session.
To get the Thank you, sir. Thank you, sir. Come inside, get them inside.
We will now proceed with the inauguration ceremony in 2 minutes.
ಶಾಲಿನಿ ಮ್ಯಾಮ್ ಇದಾರ ನೋಡಿ.
ಬರ್ತಾರಪ್ಪ.
ಅಲ್ಲಿನ ಕೇಳಿದ್ರು ಪಾಪ ಎಷ್ಟು ಬಿಡುತ್ತೆ.
ಇದಕ್ಕೆ
ಬರ್ತಾರೆ.
ನಮಸ್ತೆ. Shall I start?
Shubhodaya to one and all gathered here for the inaugural function of this national CME. Knowledge is a power, but learning is a superpower. Lawyer Jack Levin had quoted that never stop learning. When we stop learning, we stop growing. On behalf of the Department of Anatomy and Neurosurgery, I heartily welcome the dignitaries on and off the dais, the guests, the delegates, HODs of various departments, faculty members, PG and UG students, interns to this academic program. It is indeed a special year for all staff and students of Ramaiah Group of Institutions as we are celebrating the centenary birth anniversary of our founder chairman, late Sri Dr. M.S. Ramaiah. First and foremost, we are extremely grateful to our most respected Honorable Chairman, Dr. M.R. Jairam Sir, for his constant encouragement in all our academic activities. We also welcome our Chief Executive, Sri M.R. Srinivasa Murthy Sir, who has a clear vision and forethought of promoting the institutional growth to the level of international recognition. But due to unavoidable circumstances, he could not make it to this inaugural function. I wholeheartedly welcome our ever young and charming Iron Lady, who is none other than our most respected Principal and Dean Madam, Dr. Viveda Vairao. She is a good source of inspiration who motivates and guides us in all our endeavors. She is also very active in our voluntary body donation program. I extend a warm welcome to our respected Vice Principal Academics, who is always there to greet us with a big smile whenever we approach her for any guidance and suggestions. She is very supportive to us in all our activities. I would like to extend a cordial welcome to our Vice Principal and Associate Dean, Dr. Harish Sir, and also to Dr. Gurudev Sir, President Memorial Hospital, for gracing this occasion. They were both instrumental and they played a key role in catering to the needs of a huge number of patients in the hour of crisis during the COVID pandemic. A hearty welcome to our Registrar Academics, Dr. E.V. Pratap Sir, and Registrar Administration, Dr. Hemant Sir, on gracing this occasion. They are always like brothers. And actually, we should remember the attachments. Anatomists, I think they remember the attachments in the bicipital group. Latissimus dorsi, pectoralis major, and teres major. So they look like, I hope you'll remember the mnemonics, lady between two majors. So with the principal in between, then they on the right and left side, they look like the lady between two majors, remembering the mnemonic. Yes. Okay. So these two registrars, Dr. Pratap and Dr. Hemant, they always see that there is a solution for every problem whenever we approach them, and they are always ready to lend a helping hand to us. A special welcome to our Director of Advanced Learning Center, Dr. Sanjay Desai, Sir, and Deputy Director, Dr. Shakuntala, who are here to grace the occasion. Dr. Sanjay Desai, Sir, could not make it today in view of his busy schedule. Also welcome Srivara Sir, who is the head HR and legal GF, and also our Chief Finance Officer, Venugopal Shastri, Sir, on this occasion. A hearty welcome to all our eminent guest speakers who are the resource persons of today's CME. They immediately accepted our invitation without hesitation to deliver the guest lectures and be a part of this program. We are happy to welcome Dr. Shabari, who is the in-charge HOD in place of Dr. Sunil Pattada sir on this occasion. Yes. Now, we are proud and happy to have amongst us a special invitee who has arrived as a guest, Dr. V. Balasubramania sir. He is a senior anatomist from St. John's Medical College. I welcome you, sir. A special welcome to our guest speakers, Dr. Yogesh Sontake and Dr. Nupur sir, who have Dr. Yogesh Sontake is an associate additional professor from Jipmat, Puducherry, and Dr. Nupur sir is a neurosurgeon from Limans. We heartily welcome you, sir. A special welcome to all our delegates who have come in large numbers from all over the country. Hope we are able to deliver a good academic knowledge in this educative program organized today. Once again, I extend a hearty welcome to all the HODs, faculty members, staff members of various departments, friends, colleagues, invited guests, and our students. I end this welcome speech of mine with a quote from Abu Bakr. Without knowledge, action is useless. Knowledge without action is futile. Thank you all. Have a wonderful and good day. Thank you.
Thank you. Light symbolizes knowledge, unity, hope, and goodness. Light is the dispeller of darkness. We request the dignitaries to light the lamp and make an auspicious start to our ceremony. All, we now request Dr. Megha Vaira, Principal and Dean, to give opening remarks on this event.
A very good morning to all of you. Dignitaries on the dais, invited speakers, a note of gratitude to you as well for being so willing and happy to be with us today to share your knowledge. All the delegates who are actually guests of honors today, ladies and gentlemen, my faculty friends, Team Anatomy, a very good morning to all of you once again. This is an occasion which will delight anybody, and I am not an exception. But along with being delighted, I must share that it's an occasion where I am really excited. And why do I say so? About 6 to 7 years ago, when I took up this responsibility of the principal of a medical college, my first agenda was to try and break the walls between the different specialties, which we respectfully call pre-paraclinical, and the big category of clinical specialties. Whether we agree or not, there has been this kind of apparent disconnect between the clinical specialties. we just tend to forget that every specialty is dependent on all other specialties. And we tend to deliver the training in silos. It's been felt for decades that it's not helping. There have been good teachers in the past who also attempted to have applicated training, yet it wouldn't move the way it should to gain the desired outcomes. For several reasons, for a lot of new things to be put in practice successfully or implemented successfully, mandates are required. So now that the improvised curriculum mandates a competency-based training, it's almost become a necessity that all the specialties have to be connected while they plan the teaching and the training for the students. So this is now fruitful, and I really feel that my wish is fulfilled, and therefore it's a very exciting occasion for me. The credit in large part is for the team anatomy. The credit is for the entire team of faculty, supporters who have made it possible. You know, anatomy is at one extreme of the medical profession. Neurosurgery is the other extreme of the medical profession, the entire bandwidth. And today, it's wonderful to see both of them working together. Even more enjoyable is the registration numbers. It feels so good that the delegates are enthusiastic to learn the applicated anatomy. I learned anatomy about 50 years ago. I really learned it because I knew I had to pass my examination. Little did I realize how it helps on the clinical. It's only by and large because there was an aspect called lifelong learning, which was never mentioned in this terminology for us, but it just happened by default that we learned the applicated anatomy. And today, the students are privileged. And I must say that the young students are very lucky because the teachers are all trained for applicated. Another nice thing of pride which I would like to share is the dignitaries of the dais. The dignitary, Dr. Shakti, also happens to be our eminence, and he is our pride. And it was wonderful for me to share the dais with him. I wish all the delegates a very enjoyable workshop through the day. And let me congratulate and be grateful to Team Anatomy for all their efforts to organize. Organizing between two specialties can't be anything less than great artwork. And that said, I'm glad all of you are here to snatch the best from this evening. Wish you all good luck. God bless you all.
Thank you, ma'am, for your encouraging words. Now over to Dr. Veena Vidyashankar for the conduct of felicitation program. A warm welcome to the dignitaries on dais and all the delegates assembled here. Dr. Balasubramaniam V. Sir is a professor in the Department of Anatomy, St. John's Medical College, Bangalore. He has graduated from Bangalore Medical College in 1984 and has completed his post-graduation from St. John's Medical College in 1991. He is a noted e-learning practitioner and medical educationist and has 34 years experience as a medical teacher. He has served as the academic director, Medical E-Learning, MedRC EduTech Hyderabad, which has been recognized by the Medical Council of India as an excellent complementary teaching system. E-learning software was awarded the prestigious Manthan Award for Best E-learning content development. He has to his credit 60 research papers, 7 chapter contribution in various books, and is a co-author in one textbook. He has created a histology video channel on YouTube called DTS Histomed. He is also the author of software in gross anatomy entitled Windows Anatomica Upper Limb in CD format. He has established multimedia computer laboratory at the Department of Anatomy, St. John's Medical College, and piloted the establishment of learning management system for medical education. He is the recipient of Sir Shri Ram Memorial Award by National Academy of Medical Sciences India for his outstanding work in adopting modern technology in medical education for the year 1997-98. He is a member of the editorial committee of the KCA Journal and a member of various academic boards. He has received Arjuna Award and Shushruta Award from Karnataka Chapter of Anatomists. He is also the recipient of Dr. Shamay Singh Oration Award from the Anatomical Society of India. This is in brief about the achievements of Dr. Balan Subramanian sir. The Department of Anatomy, Ramaiah Medical College, feels privileged to honor Dr. Balan Subramanian sir for his outstanding contribution in the field of anatomy. We request our respected Principal and Dean, Dr. Medhavai Ram Madam, and Vice Principal Academics, Dr. Shamini Nui Madam, to do the honors. Kindly welcome you, sir. I request Dr. Yogesh A. Sondike sir to please come on to the dais and occupy the felicitation seat. Dr. Yogesh A. Sondike sir is working as additional professor in the Department of Anatomy, JITMA Puducherry, and has 17 years of experience. He has graduated from Government Medical College, Nagpur, which is popularly known as the city of Torrent farmer, sun farmer. Finally, I express my deep gratitude to each one and all who are responsible for the success of this program. Thank you. I request everyone to rise for national anthem.
is having the same features, similar features. They are third, fourth, fifth, and sixth. While first, second, and seventh cervical vertebrae are called atypical vertebra. They have little bit different features than the 15 other features of the vertebrae. Next, coming to the typical cervical vertebra. When we see the cervical vertebra, the first point should be there in our mind is the foramen transverse area. What clinical applied aspects is there behind this one? Because this foramen transverse area transmits a vertebral arm, the second part of vertebral arm. Brain receives the blood supply majorly through two arteries. One is the vertebral and another is the internal carotid artery. And due to any disorder, any disease or brain surgery, we cannot compromise the blood supply to the brain. That's what this foramen transverse area is one important point. Another important point is the vertebral foramen. So when we see this is the typical cervical vertebra, it is having body, it is having pedicle, it is having the transverse process, it is having the lamina and posteriorly the spine is there. The body of the cervical vertebra is small as compared to the other vertebrae. Means if you see the L1 to L5 vertebrae constitutes very big portion of the spine. But when we see first 7 cervical vertebrae, they constitute a small portion in the leg because of the smaller size of the body. The height of the body is very small in the cervical region. This vertebral foramen is bigger in the cervical region. Can you tell me what is the reason? Have you seen? There are certain enlargements in the spinal cord. There are two enlargements. One is called cervical enlargement, another is called lumbar enlargement. So spinal cord is bigger in this zone. To accommodate that the thick spinal cord, this vertebral foramen is bigger in the cervical region. Then pedicles are there which are directed laterally and backward. Next please. Then the lamellae. These lamellae are the longer, narrower, and thinner in the cervical vertebrae. The spinous process is short and bilobed. These are some typical features of this vertebra. We have to focus these features during the surgical aspects of this vertebrae. Then articular processes are there. The articular processes are two. One is superior, another is inferior. In this one, for the biomechanics, direction of this articular facet is very important. The direction of the superior articular facet is upward and backward. And the direction of the inferior articular facet is downward and forward. Due to this direction, variable direction, there will be more stability provided along with the mobility of the vertebrae. Next please. So coming to the transverse process. This is the transverse process, and this transverse process is having one foramen transversarium. It is also having the anterior root, posterior root, anterior and posterior tubercle. This is anterior tubercle, posterior tubercle, anterior root, posterior root, and posterior transverse bar. This is the posterior transverse bar. So this is the transverse process. See the embryological aspects of this transverse process. It is very peculiar in the cervical region. In this transverse process of the cervical vertebrae are derived from two elements. One is the postal element and another is the transverse element. So this postal element forms the posterior root. While the transverse element forms the posterior tubercle, posterior transverse bar, anterior tubercle and anterior root. So this is there. The developmentally they are derived from two different sources. In the thoracic region, there is the development of the rib, and that rib is here replaced by the anterior part of this transverse process. And that's why the vertebral artery get within the transverse process, because embryologically they have two different sources. These two different sources may lead to the different anomalies which may compress your vertebral artery either bilaterally, either unilaterally. Next. So this foramen transversarium gives passage to vertebral artery and vertebral vein and branches of the inferior cervical sympathetic ganglion. So this inferior cervical sympathetic ganglion gives some branches which forms the plexus around the vertebral artery, which may produce the vasoconstriction or regulates the blood supply to the brain. Next please. Clinically, the cervical spines, when it is clinically examined, only the spine of C7 vertebra can be palpable posteriorly at the root of the knuckle furrow on the back of the neck. Along with that one, the common carotid artery can also be palpated using this cervical spine. Particularly, the transfer process of the C6 vertebra is having anterior tubercle, prominent anterior tubercle. Against this tubercle, the common carotid artery can be compressed, can be palpated, hence that tubercle is called as the carotid tubercle. Next please. So coming to the few features, actually already in the first session we have seen this cervical vertebra. First cervical vertebra is the atlas vertebra. It is a knee-like vertebra. It does not have the body, and it does not have a spine also, but it is having anterior arch and posterior arch and two lateral masses. Already we have covered about this. When we see the anterior arch, there is one facet of the lens which where the axis vertebra articulates, the rotated process of the axis vertebra articulates. Posterior arch, which is showing one prominent tubercle here. The prominent tubercle, this is the second most prominent bony point just below the external occipital protuberance. The space between this point, that is the posterior tubercle, and external occipital protuberance, can be utilized in newborn babies for collection of the cerebrospinal fluid through cisternal puncture. So this is the sign of the cisternal puncture. That's why this tubercle is also clinically important. When we see the lateral mass, just behind the lateral mass, there is a groove, and this groove gives passage to the first cervical nerve along with the third part of the vertebral artery. Next. So coming to the lateral mass, this lateral mass is having two articular processes superiorly and two articular processes inferiorly. Already this topic is covered by sir. Next. So transverse processes, this transverse process of the first atlas vertebra is larger than the other cervical vertebrae. It has only single tubercle, but we cannot differentiate between the entire vertebrae and only one single tubercle. That is the transverse process of the atlas vertebra. So these relations of the atlas vertebra is important. Already I told this is the lateral mass. Entire this portion is the lateral mass. Behind the lateral mass, third part of the vertebral artery. and the first C1 nerve is passing, and above this one there is a bone called occipital bone. So there is a very narrow gap, and through this narrow gap, this artery, vertebral artery, is entering. Any disorder, any injury in this region may have injury to this vertebral artery, which results into the syncopal attacks. Particularly, if this lateral mass undergoes the development of the osteophytes, it compresses this vertebral artery here. So that can be easily diagnosed with the help of the radiographs and can be surgically treated. Next. Okay, coming to that axis vertebra. This vertebra, the axis vertebra, why it is called axis? Because the atlas, along with the head of the globe, rotates around the odontoid process. That's why the name came to be axis vertebra. This is the odontoid process. Actually, it is the odontoid process. It's not a separate bone. It is a part of axis, but derived from the atlas vertebra. This odontoid process represents the body of the atlas vertebra, and it gives attachment to many ligaments, specifically apical ligament and alar ligament will add. So these two ligaments are very important, and for the maintenance of stability of the vertebral joints, these two ligaments are very important. Coming to the vertebral artery, this is the vertebral artery. The superior vertebral notches here, the superior vertebral notches are strong, and the inferior vertebral notches are dull. What is the relation between the superior and inferior vertebral notches? The reason is that the compression of C2 nerve may be more common as compared to the compression of the C3 nerve. So because the C2 nerve is passing above the axis and superior vertebral notch is low, so it has the less space to come out. So the compression of C2 is more common than the compression of the C3 because C3 is having more space to come out of this gap. The transfer processes are short and spine is thick, root inferiorly and in the biped. So these are small points. Now coming to the 7 cervical vertebra. 7 cervical vertebra is called as the vertebra prominence. It is the prominent vertebra, being a cervical vertebra. It is the transition zone between the cervical and the thoracic region. So partly it looks like a thoracic vertebra. The body is changing, particularly the body instead of quadrangular, it is going to become little bit more anterior posterior diameter is increasing here. It's having a science process. Thank you. Sorry. The spinous process is thick, long and horizontal, and it ends in a rounded version. Instead of biped, it is rounded. While spinous process is biped in other vertebrae, why it is rounded? For first year students, I am giving this assignment. Okay. So one common reason here, this vertebra is palpable. Here, one ligament ends, and that ligament is called as the ligamentum nuchae. Ligamentum nuchae, as the word ligament indicates, usually we feel that it is a fibrous thing. It is having collagen fiber, but this is the elastic. It is having yellow elastic fibers more in number. That's why lots of times we can say this movement rather than saying no. Whenever sir says any assignment, any homework, no sir, I can't do it. Try to say yes, be positive. Okay, so this is not biped. Next please. Next. So the transfer process of the C7 vertebra is also large, and foramen transversalium is very small. Sometimes it may be 2, it may be absent because the vertebral artery enters in the C7 this vertebra and then it ascends upward. So here the vertebral artery is not transmitting views that so this one means sometimes it is present, sometimes may not be present. So these are the peculiarity of the C7 vertebra. Next. Coming to the joints of cervical spine. Already in the first class, we have seen that atlanto-occipital joints and atlanto-axial joints we have discussed. Now we have to see the joints between the lower cervical vertebrae, that is the typical cervical vertebrae. Next. In the typical cervical vertebrae, there are joints between the body and joints between the vertebral arteries and the joints. These joints we will see in brief actually next week. So, this vertebral bodies are connected with each other with the help of intervertebral discs, and this is called as the intervertebral symphysis. These are the secondary cartilaginous joints. The vertebral body, they have even small edges which articulates with each other, and they are called as the joint of Dashra or vertebral joints. So, these intervertebral discs and these joints of Dashra may undergo this prolapse cervical spondylosis or osteophyte development. The next speaker will deal with this. Next, please. Coming to the joints between the facets. These are the joints between the facets or zygomatic joints. These are the joints between superior and inferior articular processes. These are the plain synovial joints and permits only the gliding movements. Intervertebral syndesmosis. This intervertebral syndesmosis means the remaining arch are connected with each other with the help of various ligaments, and that ligaments itself forms the fibrous joints. So that's what they are called as intervertebral syndesmosis. That is the joints between the two laterally, joint between the adjacent spines, and joint between the transverse processes. The ligaments are ligamentum flavum, supraspinous and infraspinous ligament, interspinous ligament, intertransverse ligament. So these ligaments provide stability to the joints. Little bit about the intervertebral disc. When we see the intervertebral disc, it is nothing but a wide fibrocartilage, and it forms a secondary cartilage in the joint. Its thickness is 7 to 10 millimeters. It depends on the person to person. It is variable, but it should not reach below the 7 millimeter. It contributes about the 1/5 of the total length of the vertebral column. This intervertebral disc is having two parts. The central core is formed by nucleus pulposus. This lies in the center and consists of soft, gelatinous, mucoid material. The mucoid connectivity should be remember where it is present in the embryo. Very good. Umbilical cord and protocord. These two places, the mucoid connectivity should be present. Umbilical cord sits on the wall, but it persists. But slowly, this mucoid connectivity toward the protocord is desaturated in the first decade, and mucoid material is replaced by the remaining portion of the fibrocartilage. Then coming to the outer zone, that is the annulus fibrosus. This is the peripheral part. This is only the main part which is going to derive from the 15 to 20 concentric lamellae of fibrocartilage. Alternate layers of the collagen bundles, and interact between that layers there are the chondrocytes. That's why it is called fibrocartilage. The fibers in this lamellae, they are arranged perpendicular to each other. In the adjacent lamellae, they are arranged perpendicular. When we consider this beam, we arrange some rods vertically, some rods horizontally. The rods are arranged perpendicular to enhance the tensile strength of the column. Like that one vertebral disc is a small column actually, and to enhance the column, the fibers are arranged in the different or perpendicular manner. So it gives shape to the vertebral column. This intervertebral disc acts as the shock absorber, particularly in the early age till the nucleus pulposus is there. The kids can do many movements, but the movement starts restricted because of this shock absorption. Along the slight movement and weight transmission from one vertebra to another vertebra, these are the functions of intervertebral disc. Blood supply of this intervertebral disc is also very important. Only the peripheral part receives nutrition directly from the blood vessel. The central zone of intervertebral disc receives the nutrition by diffusion. So any cutoff in the even a small cutoff of the blood supply may this central portion may undergo the necrosis. So what are the movements at the cervical spine? At the cervical spine, we can do the extension and flexion, not only at this atlanto-occipital joint, but entire neck we can do the extension and flexion. We can go to the movement of right and left, that is the rotation movements, and we can have the lateral flexions. So these are the movements of the cervical vertebrae, cervical spine. Okay, now coming to the brief about the thoracic spine. When we see the thoracic spine, it consists of the 12 thoracic vertebrae. Any thoracic vertebra we can easily identify by presence of the costal facets. Costal facets are present only in the thoracic region. Why? Correct. Ribs are present in the thoracic region. That's why they have the cervical costal facets. Okay, they have the curvature. Thoracic spine is having anterior curvature, that is the primary concave curvature. Thoracic vertebrae are grouped into two, that is the typical and atypical. T2 to T8 are the typical vertebrae. Okay. So what are the features? It is having the body of the thoracic vertebrae is arched and it has articular facets. It has articular facets. The vertebral foramen here in this region is little bit narrow. The reason is that there is nothing enlargement. The thoracic region is not having enlargement like the cervical and the another enlargements. So this vertebral foramen is small circular foramen. It is having the spinous process which is long slender with a rounded tip. The pedicles are attached to the upper part of the body. That's what the inferior vertebral notch is there. The passage for the thoracic spinal nerve is very good. That's why you might not have heard about the nerve compression in the thoracic region. Usually we hear the nerve compression in the cervical region and in the lumbar region because the passage for the spinal nerves are narrower in that. In the thoracic region, the passage for the nerves are very big, very nice. So nerve compression in the thoracic region is less common. So body we have already seen, but the body is having two facets usually to the typical thoracic vertebra. One is the superior demi facet and another is inferior demi facet to articulate with the ribs. And this is the transverse process which is also having the facet, the facet for the corresponding to rib. So these are the facets which are present in the thoracic spine. When we see the thoracic vertebrae, this thoracic spine, they are supported by a number of ligaments, particularly this is the anterior longitudinal ligament, which is running on the anterior surface of the body of thoracic vertebrae. Just behind this one, there is the posterior longitudinal ligament. Then these are the lamellae. Adjacent lamellae are connected with each other by the ligamentum flavum. Then transverse processes, adjacent transverse processes are also connected with each other by intertransverse ligament. Then these adjacent spines are connected with each other by the interspinous and supraspinous ligament. So these ligaments permits mobility also as well as stability also. They permit little bit movement. The movement in between two vertebrae cannot happen too much. But when we see the entire thoracic spine, there may be a certain movement, right? Like lateral flexion, forward flexion, backward extension, or rotation. So entirely all the vertebrae may move together and they produces certain movements. So I have given one brief things about this one. Okay, so there are the superior articular processes which are the articular processes are there, superior and inferior articular processes. Superior articular process is directed backward and inferior articular surface process is directed forward. When we compare this with the cervical vertebrae, the direction of these articular processes is different. That's why cervical vertebrae are more mobile. Thoracic vertebrae are less mobile due to the direction of these articular processes. Next. Okay, so these are the joints between this ribs and the thoracic vertebrae. Here the ribs are forming the joint with the transverse process, and that is called as the costotransverse joint. This costotransverse joint is the plain synovial joint. The ribs also articulates with the body of the adjacent vertebrae, and that joint is called as the costovertebral joint. This is the costovertebral joint, and this costovertebral joint, the plain synovial joint. So that's all about this today's session. I have finished. Thank you. can understand the description of the thing. We have discussed, my speaker and I have discussed very well what I will cover, what sir will cover, so there will be. Thank you so much. Next, please. So there are certain movements which can occur, that is the rotation, forward flexion, extension. So these movements can occur at the cervical spine. Next. So these are what I have written. The books are there. Next, please. These are the books that I have. Thank you. Thank you.
Thank you, sir, for the wonderful presentation. Now, I request Dr. Mitchell Putty, Professor, Department of Neurosurgery in Hands, Bangalore, to hand in the memento to Dr. Yogesh Centenary. Thank you, Dr. Mitchell Putty. Thank you, sir. Now we move on to the next presentation. I call Dr. Anupama K, Assistant Professor, Department of Anatomy, to introduce our speaker, Dr. Pariksha. Pariksha J. Pariksha is Assistant Professor and Consultant Neurosurgeon in Ramaiah Medical College and Hospitals. He has completed MBBS from Jawaharlal Nehru Medical College, Belgaum, MS General Surgery from JJM Medical College, Bangalore, and SCH Neurosurgery from MS Ramaiah Medical College, Bengaluru. He has 11 publications to his credit. He is also a certified ITLS instructor. His areas of interest are minimally invasive and endoscopic spine surgeries like discectomy, unilateral approach for bilateral ramiotomy, and pedicle screw stabilization. He is proficient in endovascular neurosurgery, open spine surgeries like cervical junction, surgeries like cervical hyperpass fixation, C1C2 fixation, occipital cervical fixations, and many others. He has been a resource person in many workshops conducted in Ramaiah Advanced Learning Center. We are pleased to have you here, sir. Now I request Dr. Pariksha to take over. Thank you.
Talking about applied activity of spine and invasive, so we should cover this topic. Which, the long surgery, physiotherapy, etc. are considered I would say that prevention is best. And as we know, the forming of prevention parameters actually broke the back of the Japanese. So you are only as strong as your back is. Makes it everything and makes it for the how do we get finance and so the production and number of the side. And this is very correct. Each of the individual joint is complex and on side is the facet joint. So the facet joint it is formed by the inferior facet of the superior vertebrae and the superior facet of the inferior vertebrae, and we have on either side of the vertebrae, totally including the space we have totally joined at the level. And many of our vertebrae have joints spinal vertebrae, sacrum, skull, and other structures. So all in all, our spine has about 64 joints, and it's like about one joint for every day in a year. So it is the coordination of these joints which help clear the spine when which extend in different directions. So it's important to know the angles that these joints are formed. In the surviving joints are different at 45 degree angles in the horizontal plane. And whereas in the thoracic vertebrae, it forms an angle of 60 degrees to the horizontal plane, whereas the facets in the lumbar vertebrae form an angle of 90 degrees to the horizontal plane. Coming to the intervertebral foramen is formed by so this forms the foramen to which the nerve to penetrate the spinal cord. So and every level we have a pair of and the ligaments that connect the vertebrae hold spinal position. So there are two primary ligament systems. This the biggest system is there and these two primary ligament systems can be divided as intersegmental and intrasegmental and intersegmental. So the intersegmental ones are mainly for the individual vertebrae together include the ligamentum flavum, which is close to the dura, then the interspinal ligament and interspinal ligament and supraspinatus ligament, whereas the intersegmental ligament, that is the anterior longitudinal ligament and the posterior longitudinal ligament, and all along the spine, and it goes to the vertebral column and gives support to the vertebral column. So, coming to the intervertebral discs, we have cervical, thoracic, lumbar, intervertebral discs, and columnar discs. So, intervertebral discs serve primarily for along movement between adjacent vertebrae bodies, and it absorbs shock and tries to go to the vertebral complex morphology of the structure of the neurosurgery disc of the lumbar spine reflects these functions. Apart from the shock absorbers, torsion helps and aids in spinal flexion and extension. So the previous speaker has spoken about the neurovertebral disc in detail. What is clinically important is that when soft this fibrosis gives way to the fibrous annulus, the annulus fibrosis, and it dissolves into the spinal canal or the compresses the foramen. So then it becomes permanent. So we'll see how we deal with the spine. Normal spine has a S-shaped curve when viewed from the side. This allows for even distribution of weight and flexibility of movement. Spine curves in the following ways. Mainly the cervical spine forms a reverse backwards C-shaped curve, or we call it an auditory curve, and the thoracic spine forms a some abdominal it can be strong or whether it's polish or it's of the spine. So we can be either conventional or we can do conditions and listening as a population. These abdominal parameters of spine may be corrected with surgery. So the normal thoracic kyphosis average is between 35 degrees. Normal range is 20 to 50 degrees. And coming to lumbar lordosis, the average of lordosis is that the average of lordosis is between 30 to 50 degrees. When the lordotic curves more than 70 degrees, it is considered normal. Average lordosis is very less, that is around 10 degrees. So, coming to the pedicles of the vertebrae of the body, what are pedicles? Why is it important? The pedicles is like a stub of bone that connects the lamina of vertebrae lamina to the vertebral body. These are two short stout processes on the right side which connect the vertebral body and then continues with the lamina and forms the spinal canal through where the spinal cord is protected. Why is it important? Clinically importance how the pedicles are because whenever we have to stabilize the spine, we have to put the screws through the pedicle into the vertebral body to form a construct between two vertebral segments. So, hence the pedicle length and diameter is important. So, when we see, as per the studies, we see that the T4 pedicle is the smallest in length and diameter. And as we come down caudally towards the lumbar and sacral vertebrae, the pedicle length and diameter increases. And in the sacral, it is around 2 centimeters pedicle diameter, and in L5 it's around 3 diameter. Whenever the pedicle screw is inserted from the rotoscopic that is apart from the diameters, we have considered that is one little line which we could see screw into the vertebral body for the pedicle and transverse angle. Why these two are important? Because addition to the pedicle is affecting nerves. So if the screws are not, if the screws are malpositioned, then it will injure the bond. If it goes to medially or if it goes to laterally, it might not form a stable construct. And hence these two angles are important when we are inserting the pedicle. Paracentric muscles and connective tissues are also being supported by the spine. Coming to the symptoms with which the patient presents in the spinal problems are really accidents. These are the most common chronic conditions in India. Frequent 4 out of 5 men will experience low back pain or neck pain at some point of time in their life. When these symptoms are treated within 6 weeks or they remain for consultation or is acute, and when they last more than 6 weeks in chronic conditions. This deep spinal anatomy overview, let's see the most common affected conditions of the spine. Acute strains and strains. This all of us would have experienced at some point of time, and most of the time they will be managed with some analysis or therapy. However, more important things are disc bulges, disc herniations, and degenerative disc conditions and vertebral fractures, which sometimes may require, which most of the times may require surgery for further environmental injuries. These discs, these discs have sensory receptors. This can degenerate, that is, there can be loss of disc space height, and they can bulge or herniate because of any rotational forces or flexion or any injuries. And once it herniates out, that is the nucleus purposes to herniates out and it sits in the spinal canal or on the AVP nodes. So in this picture you can see various stages of disc herniations. This is the stage 1, that is the disc degeneration. Here nucleus pulposus is still there, but there are few, the nuclear annulus fibrosus is weakened. Still the bulge is very minimal, so this stage of disc degeneration. Coming to prolapse nucleus pulposus, through a weakened annulus is almost about to, the nucleus annulus fibrosus is almost about to give away in this. So there is a stage of prolapse. When the annulus fibrosis gives away, the pulposus, which is soft, comes out, and this is the stage of extinction. So there can be sequestration. When there is sequestration of this nucleus pulposus, either it can be the spinal can migrate in the spinal canal downwards or upwards. So this is how a herniated disc is, and it is thinking upon it is pressing the exiting root against the bony structures. So that's the reason patient present with severe less common causes of back pain are fractures due to trauma, fall, osteoporosis, rare infections and tumors. Fractures can vary from less debilitating wedge compression fractures. This is a picture where the MRI is showing a wedge compression fracture. Usually patients present here with bony pain because in wedge compression fracture, the spinal canal is usually not compromised, so the spinal cord and root are not compressed. And you can, when both the anterior and posterior elements are involved, we can have such dislocated fractures where the spinal cord injury is very significant. And patients usually present with and dysfunctions for like paraparesis. Here we have to stabilize the spine and other factors for developing back pain and head pain are poor posture, occupation, really activities, or the spinal solutions, scoliosis, osteoporosis. So all these most said spinal conditions, when they require surgery, based upon that, we need to perform a laminectomy. This is the most initial conventional surgery done for the spine when there is compression on the spine for the use. So it's an animation of how the laminectomy is. So here there is a midline incision which is done and the muscles are retracted on other sides. So this is the spinous process. At the exact level, we do the spinous process and the lamina. So once you do the spinous process and the lamina, you see the cord. So whenever there is a compression from anteriorly, so we do this, and when the foramen is again leveled off, so that everything now goes free and there is no compression. So when this is about the laminating, then there is a simple display can be done when the symptoms are mainly identical, and here a single laminectomy is done and the nerve root is extracted so that the extruded disc fragment is excised and the nerve root is. So sometimes when the joints are unstable or when the stress joint hypertrophy or spinal canal access because we put some name of hypertrophy, it is compromised, we use stabilization across the adjacent vertebral segments. So here the facet joints also are excised so that there is adequate decompression. So we put particular screws and stabilize These are all conventional ways in all the time. So laminectomy procedure we use to quite convincingly dates back to the 19th century when which many milestones and techniques have been described by various surgeons over the years. And towards the early 2000s, moving science has gained popularity as it delivered better results than conventional movement surgery. So in conventional approach, we treat spinal conditions which involve extensive iatrogenic trauma to the or disruption of the of the back is very important. So here is how picture you can see this being start surgery. And whereas adult minimal invasive techniques are the same but not significantly treated with a lesser invasive approach and disruption of muscle architecture supporting the so most of us, whenever there is an requirement of a patient who wants spine surgery, the first question is spine surgery safe? This is the appearance to the appearance of the patient to be presented. So there are many misconceptions, I would say. Then exactly appearance is what the person asks, should I get paralyzed? Should I get able to walk away? What if I lose control over my bowel and bladder? So it's a common so I would say everything in life comes with an element of this. So usually the benefits outweigh the risk by factor of 10 to 1 in spine surgery. And with the recent advances in spine surgery with movement in the orthodox and endoscopic approaches, I would say the risk of iatrogenic injury to the cord and the nerves are still in the hands of the brain surgeon. So why does the paradigm shift in the way spine surgeries are done? If you go by the basic tenet of surgery, it states that most effective way to treat a pathology, there is a movement disturbance of normal anatomy, thus leaving behind the smallest footprint on the This is actually by the movement in the spine surgery. Any surgery means there is damage to tissues, and which in turn means there is pain or loss of function, and due to tissue damage. In minimal invasive spine surgery, there is significantly less tissue damage, and exception is functional outcome is better, and recovery is faster and more satisfying. So hence, minimal invasive spine surgery circumvents diabetes in the 180, making surgery more area procedure, and this captures the interest of both the surgeon and the patient. Minimal invasive procedures on spine can be broadly classified into endoscopic based procedures where usually endoscopic discussions are done or a tubular refractive based procedures where we do a movement in then lumbar inward fusion and that is why for understanding approach or concept of so here in this patient, patient presented with a L4-5 disc collapse. Here you can see this is an MRI skeletal view where the spinal the disc is collapsed and it is compressing on the spinal cord. So in the axial sections, you can see this is the fragment of the disc which is compressing on the cord plus anything else. So what the aim of the surgery here would be to excise the prolapsed fragment of the disc. So how it is done? So these are tubular dilators. So these tubular dilators, we mark an incision 1 centimeter lateral to the midline and make an incision on the skin and fascia. With these tubular dilators, we lock these dilators at the junction of the spinous process and lamina. And serially one over the other we dilate and the muscles are retracted. The muscles are not just separated and just. So once we do this, a working standard tube is put over these dilators and it is fixed to a stand. So basically we are working through this small pore compared to an extensive surgery where you would have opened the spine in the midline and separated the muscles. So what is the view? So this picture helps us to understand how it is. So we do this docking of the view and the desired level with the help of a C-arm. So this is how the view would be, and we have the spinous process and the lamina junction. So once we separate few muscles or muscular muscles over the lamina, and then we do the laminectomy and remove the bone, and if we have to separate the foramen, we
can be the foramen. So, this fragment only retracted downward medially in the first subsequent stage. So, this, yeah, this is a new property of microscope. Here, the dura is retracted, the dura and the spinal cord, the exiting root will be there. So, this is retracted medially. So, basically, here we can see this is the dura and the root which has been retracted. So, now this is the fragment, the disc which is a prolapse. So, this is being this is coming out. So, this is a fragment once it is out. So, and finally, once we remove the fragment and make sure that all the fragments in the disc space are out. So, this is the prolapse fragment is out. So, once you release, the root will be lax. So, finally, once you remove the working side tube, all the muscles fall back into place. So, there is no disruption in the muscular architecture. This is how the scar is posted. So, coming to another case, here, the patient presented with right-sided C7 prolapse disorder. So, this was the something on the exiting road. So, similarly, on the CM side, the standard address or clay address C7. So, this is what I was saying about the CM. CM will be taken as a drops after releasing the tube and putting in the direction. So the tubes are fixed. So this is how the individual was like these are the tubes and the working generator tube which is to a standard with this and confirm with the CM. For better understanding how this study was done, you can see here what was done was there is a fragment compressing on the existing root. So part of the lamina with the facet medially was drilled and a window was made so that you can see the existing root from scar. So whatever is infringing from stand, so the gentle retraction or easing the extruded fragments, the sac was removed and we allowed for that. So this will follow the so, and in this case, this patient had presented with axial backache with ambulance not able to walk more than 15 meters. So here we can see in the picture the MRI where it is hypertrophy of the catheter level and severe primary canal stenosis. So this is a sign for lumbar area. So this is planning is also important. So this here we mark the lateral pedicle lines. Here is the pedicle taken in X-ray. So these all shaped images on the X-ray is the pedicles. So this is important because there is a lumbar area two aggressive vertebral segments. So for that we need to insert the pedicular screws. So this lateral pedicular line helps us to angulate angulate the pedicular screws. So this is important in the planning. So similarly, with directed tubes, we talk the working channel. So here this is here the working channel tube. It is slightly docked more laterally compared to the discectomy, where the facet joint has to be seen. So this is the inferior articular process or the inferior facet, and this is the superior facet. So this is how intraoperative will look like. Very confusing. So then once these facets are drilled and removed, then you find the ligament of Flavum covering the dura. So the ligament of Flavum also is excised. So following which you can see the dural structure. This is the traversing root. This is the root. So that is retracted immediately. So you can see that this is space. So once the disc space is seen and the roots are protected, we do a discectomy with and share here in the really important thing, try to remove the disc, the material completely prepare the plates, that is like a shade and place, and we to replace the disc, we put a interbody spacer or we call it like interbody cage So the shape in this picture, you can see that this is being prepared. This case is being prepared, and then we put a intermodal case. So this is the field of view seen through the tubular diameter. So we work with so what we have done in this case is like so the entrance of the bed and the cage is being inserted to maintain the space height. These are the pedicles to inserted with the pedicles. So and then on either side it is stabilized with the rods. So main aim of this surgery is to increase peripheral diameter and then make sure the existing units are free. Now this patient had antibiotic spondylosis due to past fracture. So here you can see that the spondylosis in the past. So then there is an anterior discusses of L5 covered with the one. So here is similar freedom procedure or was done. The main goal of the surgery was to reduce the discusses and make sure the actually good fast. So this is the final image after reduction. So this is video of so apart from minimally invasive surgeries, the other one how the technique or the remote advantage get about endoscopic spine surgery. This is an intraoperative video of hysterectomy. So here this fragment is already out. So here the visualization is much better compared to a tubular retractor based procedure. Here you can see the dura. This is the dura, and this is the thing which is flapping here. Okay. So we retract the root and so once we divide the root, you can see this is the annulus fibrosis through which this fragment has come out. Yeah. In this picture, we can see this is the fragment which was removed by endoscopic hysterectomy. So compared to tubular dilators, where like told incision is around 1.8 centimeters, here around centimeter. So here it is lesser disruptive when in endoscopic spine surgery compared to tubular surgeries. We have done a comparative study between open and so there was a improvement in the mass score, and there was increased bed loss and operating time, and the hospital stay was lesser in patients who were subjected to say that any procedure there will be limitations. Okay, the main limitations of the advances are it has a steep learning curve and learning curve use the system efficiently and safely on the patient. And there will be like any open surgery, the chances of dural tears are there during the surgery. And this is anything but also and be describe the dural substitute or I would like to conclude by saying that individual spine surgery for the patient is extremely important and there is increased safety because of the visualization and the recovery is faster and less extremely and there is more precision in getting the type of patient getting out there.
Thank you, Dr. Balki. Now I call Dr. Priya Rana, Professor Lecturer, Department of Anatomy, Bangalore Medical College and Research Institute, to hand over and go to Dr. Balki.
Introduction
Thank you, ma'am. We move on to the next guest lecture. I call upon Dr. Pratap Kumar to give brief introduction to our next speaker, Dr. Shabir Divish. Over to you, Dr. Pratap.
కొంచెం perfect scene again.
They completed his undergraduate from Ramaiah College in 1989. And he has finished his MD surgery from Bangalore Medical College in 2006. He did his MD neurosurgery from Christian Medical College in Indore. He has been awarded fellowship in epilepsy and functional neurosurgery in 2019. He has 13 publications to his credit. He has done more than 12 conference presentations. He has participated and conducted 22 skill workshops specific neurosurgery, and his areas of interest are epilepsy surgery, functional neurosurgery, pediatric neurosurgery, and cell-based surgery. He has actively participated in many patient education programs and community services to Stop Diabetes Campaign, Pulse Polio Campaign, Tsunami Medical Relief activity also. Thank you, sir. Please take over.
Thank you for we are trying to start off with an insight of topic starting from the central core, which discussing the microfiber tracks. Then, of course, the blood supply. So, today's discussion, my talk is on basal ganglia. And this is one of the relevant topics for all the undergrads and keep in mind when we all study basal ganglia. Basically, because it is a three-dimensional structure with a lot of nuclei and pathways and all that. So it is nightmare when we take an exam and this hope I'm trying to simplify it. I think we are very grateful to all the anatomists who have given their to develop the knowledge on this complicated structures, where now we have very good three-dimensional understanding of every single part of this basal ganglia, not just the knowledge. We are even targeting every single nucleus in the basal ganglia for all the major illnesses which are functional, like epilepsy, movement disorders, and for that matter, psychiatric disorders. So, this is going to be the outline of the talk. So we'll start off with the basic cadaveric anatomy, and then we will try and understand the three-dimensional orientation of the structure. Then briefly about the pathology and functional networks. We being a student, I would want to focus more on the applied aspects of this anatomy. Then of course the imaging and functional targeting and all these other things that are possible on this structure. So to begin with, what are the basic components? So try to consider from anterior to posterior. These are the structures that would appear. And the complicated structure is mainly because of the orientation around the ventricles. So just to summarize the entire structures of the basal ganglia, the lateral nucleus, filament and closed parallels, substantia nigra and subthalamic nucleus. These are the very important structures which constitute basal ganglia. So subthalamic nucleus and substantia nigra, though they are outside the central core, they form a very integral part of the basal ganglia, which we are considering that as a single unit. So briefly, the cadaveric disposition and trying to understand how the cadaveric approach for the basal ganglia is. Yeah. So this is the outermost aspect of the basal ganglia. Maybe you want to consider any certain sign of the approach begins from the insula, the lateral point, and the medianmost point is going to be the ventricles. So what is shown here is the head of the caudate nucleus, which is the only structure which is visible to the naked eye when we approach the ventricle, which takes the floor of the lateral ventricle. Around which there is a thalamus, which is again a central core, which is very important nuclei, and this is another very important component of the basically structure as such, that is substantia nigra. And just below the substantia nigra is the subthalamic nucleus right under the thalamus. So this is the entire structure of the basal ganglia. So there are various landmarks that we discussed when it comes to the basal ganglia components. So to begin with, there is the corpus callosum, then the lateral ventricle, then the third ventricle. On both sides of this third ventricle is the thalamic nucleus, and below this there is the inferior temporal horn of the lateral ventricle. These are the very key structures and key landmarks based on which the entire stereotactic and functional neurosurgery is based. So another very important key component is the internal capsule, which goes right through the basal ganglia. And how these are arranged, I'm going to explain in the 3D modeling of this basal ganglia. But to have a rough understanding, the basal ganglia is divided into medial component and the lateral components. Medial component is medial to the internal capsule, lateral to the internal capsule is the caudate and the lentiform nucleus. So to begin with, that is the head of the caudate. This is just in one section. It's a C-shaped structure which goes around the thalamus, which is very important to understand. And then it becomes the lentiform nucleus, which has two components in it, putamen and globus pallidus. Again, in globus pallidus, there are two sections. See what there are two globus pallidus internal and globus pallidus external. So this is one slide to give you an axial orientation to it, where you can see the anterior limb of the internal capsule, which is one structure which is in the radiology of this region. So in relation to that, that becomes the head of the caudate nucleus, posterior to which there is lentiform nucleus. And another very important structure, which is found in the junction between this lentiform nucleus, which is globus pallidus and the putamen, and then the anterior caudate. So the putamen is lateral to the globus pallidus in the axial orientation. This forms the insular cortex. As I showed, that becomes the lateralmost key structure in the axial orientation. So what has been shown is the nucleus accumbens. So that term is, I mean, it is really alien to most of the orthodox anatomy structure. It comes to psychiatry. Even though there are different things to test the behavior of individuals, various addictive disorders have been treated by targeting this particular structure. So it is called ventral stratum at the junction of the caudate and the lentiform nucleus. So now let's see how the 3D reconstructed basal ganglia can be clearly explained. So to understand the basal ganglia structures which is around the ventricular system, you need to compare one of the guides what we showed here, which is the ventricular system. So the C-shaped curve is the lateral ventricle, with the third ventricle joined with the foramen magnum, and the fourth ventricle is communicated with the aqueduct of Silvius. I'm very sure ventricular anatomy is easier and more familiar with it. But how is the basal ganglia, which is organized around this ventricular system? How can it form key landmarks for it? So this is the thalamus. To begin with, that's the medialmost structure, just lateral to the lateral wall of the third ventricle. That is the structure that begins with, and around which the caudate nucleus is arranged. This is very important to understand because whenever we look at an MRI or whenever we take a slice of coronal orientation, this is very important to understand that the caudate runs entirely around the ventricular system, beginning from the frontal horn of the lateral ventricle, which is found in the floor of the lateral ventricle. Then it goes around and along the roof of the temporal horn, the caudate nucleus ends, which is the tail of caudate nucleus. So this is a very important structure. I guess all of you can figure out what the structure is. This is the internal capsule. From the coronary radiator, it condenses into a thin sheet of white fiber tract. All of you saw it in the previous cadaveric approach, but this is how the three-dimensional disposition is.
This is very vital to understand, and this is exactly what we target when we do the hysterectomy for hemispheric accuracy surgeries. So just that little capsule lies in the hollow formed by that little capsule is the lentiform nucleus, starting from globus pallidus, which is medial most, the internal and external segments, and then just lateral to it is the putamen. So this is how the key structures are organized around the system, and this is how the key landmarks are formed for our own targeting that we're going to do it in functional surgeries. So that's the ventral diagram that I was talking to you about, where the caudate and the abdomen is joined. This forms the ventral striatum, or in other words, nucleus accumbens. So the striatum derives its name because of the striated gray matter which passes through the internal capsule and forms striatums, and that's the reason why it's called striatum. So as we move on, we find various such combination of terms. For example, there is lentiform nucleus, which is actually the putamen globus pallidus. There's striatum, which is human caudate. They are very functionally integrated structures, and because of which it derives various terminals. At times it is confusing, but if you look at the functions, it will be very easy to remember. So, as I said, it's very important how we correlate this three-dimensional knowledge to the MRI, which is very important for us as a treating physician, as to understand how the orientation of these ventricles comes in the physiology. This is a T1 image slice where the 3D integration has been done, where you can see the ventricular system below which, as I said, the caudate nucleus. As you can see, it's just a thin slice that we want to see it. So from anterior to posterior, we need to have this slice orientation, this three-dimensional orientation, without which we will not be able to treat any diseases that are affecting the distal ganglion. So from superior to inferior, the medialmost structure, as I said, is the thalamus, and the lateralmost structure becomes the lentiform nucleus with the internal capsule in between that. So when it comes to the functional aspect, basal ganglia, I feel, is in a hierarchical evolution. This is important for various fine movements. I would say it's a sort of filter, or sort of whenever a person wants to move, or whenever some fine movements in the hand happens, basal ganglia is the one which makes the difference between human beings and animals, I would say. Not just in terms of movements, in terms of even the emotions. The filter that we have is fine modulation that happens in the human brain is brought about by these structures. So we have three very important anatomical moves, which are cluster motor, associative, and executive. And fortunately, every single nuclei is available for us, and it is at our disposal for the treatment of any ailment which is being affected, starting from epilepsy, movement disorder, and the psychiatric diseases. All these targets can be used because of the all the advances that are being speed. So this is another when it comes to the exams, basically in your pathways. There's so many integrated networks which are very important to understand, very vital to understand the pathophysiology. So one way to look at this and to understand the key structures so that you'll be able to remember the pathways better and the pathophysiology associated with them. So there are two pathways, direct and indirect. The direct pathway starts from the cortex, sends an excitatory input to the striatum. Striatum is the receiver of basal ganglia. The transmitter is internal globus pallidus. So here, those two are directly connected. From the input from the substantia nigra, there is double inhibitory pathway happening. Once the inhibitory input comes into the internal globus pallidus from the putamen and the caudate, then there is another inhibitory output goes from these structures to the thalamus. That is the ventrolateral aspect of the ventrolateral nuclear group of the thalamus. So there are double inputs that are coming in from the basal ganglia. But the design is so beautiful that the final outcome is going to be excitatory. So as you see an indirect pathway to begin with, you will understand why this entire model is coming in. So when there is inhibition of the inhibitory signal that is coming, the ultimate outcome is going to be excitatory. So always the thalamocortical output is exciting. There is a modulation of this thalamocortical output for a reason. There are in fact inspiration, artificial neural networks that are coming up based on these structures. It is very efficient when the cortex sends off a signal that has to be filtered at the basal ganglia level. Every motor output that goes out from the pyramidal cell goes to the basal ganglia and then even back to the cortex for its final adjustments so that the output is not overshot, so that the final movements are executed. But there has to be a check. Whenever a person fails to flex his arm, the extensor compartment has to collapse. So that comes from this indirect pathway, which is largely inhibitory. So there is a facilitation of flexion movement by the direct pathway. So the other antagonistic muscles has to be inhibited for the final movement to happen. And that happens through this indirect pathway where there are two extra structures that are coming into play. That is external parietal. And if you remember, the projection was directly to the internal parietal, which is actually an output fiber for this ganglia. But here is where the output goes to the external parietal. From there, it goes to the subthalamic nucleus. So, subthalamic nucleus and the internal parietal is considered as tonically inhibitory group of neurons, where the outputs are always inhibitory. Based on the modulation that happens from the inputs coming from the cortex, based on the movement that a person wants to do, that signals are modulated to these inhibitory nuclei, so that the final movements are very smooth up to the mark and human in put together. So there is direct pathway to facilitate your agonistic muscles, and then the indirect pathway to suppress the antagonistic muscles. So there is a very vital interplay between these two pathways to take care of the final movements, which are evolutionally in the topmost hierarchical strata. So, briefly about the pathology before I would go into my the surgeries and all that. It's really important to understand what exactly happens in those pathways we have. The reason behind it is basically the oligomers and fibrils. Those are misfolded proteins which are supposed to be digested and taken removed from the neuron. For some reason, ways for it by microchip. There are various phagocytic activity being affected, but in general, this is what happens. The Lewy bodies or abnormal proteins get accumulated and they release the cycle of these. Help them by releasing replacement drugs, but ultimately they end up with the brain stimulation that we do, where we stimulate the subthalamic nucleus, which is the inhibitory thing, and we do that by hyper stimulation. We are actually suppressing the activity of subthalamic nucleus, so to facilitate the movement that are happening. So that we will try to understand when we look at the clinical aspects of it. So how do we really train them, and how is this analytical knowledge taken to the surgical part of it? This is one of the most important landmark development that has happened in terms of functional neurosurgery. This is a Shackelbrand Warren Atlas developed by the neurosurgeon, the collaboration between the neurosurgeon and the neuroanatomist, where there is a multiple slices have been taken from the catalogs way back in 1956, and then photographic microplates have been developed to develop this sort of the coordinates to know what structure comes next from the midline. And we have an internal reference mark, which is called ACPs, the anterior commissure and the posterior commissure, which forms internal reference, from which we take, these are the 5 meter midlines, which gives us the rough coordinates as to where the target is going to be, and that will be targeted. for various segments. But this is what the technology has taken us into. Now we can do the same thing using the MRI images, where we do a functional MRI, basically a volumetric acquisition of the brain, and see these structures, with our naked eye, and choose the target, and then automatically the coordinates are developed. And these coordinates are important basically for this particular reason. This is the basic workhorse of any functional neurosurgery that can happen. We cannot open up these ganglia, unlike any other structures in the brain. We cannot directly go to the subthalamic nucleus with any sort of nuclei, and we use the neurophysiological. As we go in, every single layer gives a very distinct neural signals based on which we can identify where we are. Even without image guidance, we can do this. So first, we have gone to a stage where the frameless neuroplasticity has come. For the longer time, I skip that far. But just to give a brief idea as to what we are doing to help patients with movement disorder, I think Anish is in the crowd. These are movement disorder specialists. We form a team, and it's a big thing, not just movement disorder specialists and movement disorder surgeons. There's a huge team behind this to help patients with functional disorders. So this particular surgery is done for Parkinson's disease, where the lesioning is created in the hyperactive nuclear group, which I just showed. We are targeting globus pallidum ether. As I said, it is tonically inhibitory. So by creating lesions using radiofrequency thermocoagulation, we target the globus pallidum ether and create lesions which takes care of all the symptoms a patient has in Parkinson's disease. So this is how the lesioning looks like. You can even remember the slides axial machines I just explained. You can see the different layers as well. This is kind of external, that's internal, and that's how the lesioning looks like in the post-op MRI. So now we are moved away from lesioning because it's a one-time procedure and the side effects cannot be reversed because you're making a destructive lesion. So now comes the era of deep brain stimulation, where we put in the electrode, we can control very precisely how the nuclear group should interact with the other group. If it is hyperactive, we can make hypo. In the hypo, then we can even make it hyperactive. So we are modulating the entire basically structure by choosing a very key modal target. Once this target is subthalamic nucleus, and fortunately or unfortunately, we cannot create lesions in this place because subthalamic nucleus lesion, as you all know, will cause hemiparesis. So there are no subthalamotomies performed, so we start with that. So now there are going to be image stimulation for this target, and this is something called direct targeting, where we'll be using the landmarks in this particular section. So that's the nucleus that you see. Just lateral to that, with some more features, there are some Mejri lines and CBB line that we are supposed to follow, and then arrive at the target and figure it out that that is a target that I don't want to touch it. Basically, because subthalamic nucleus is all about 8 to 10 mm in size. Within that subthalamic nucleus group, there are 3 subgroups in that. Which will take care of the limbic system, which is going to take care of the associative system. So we need to target the motor aspect of this 8 mm nucleus. So that much precision is required to target the dorsolateral aspect of the subthalamic nucleus. So there, this 3-dimensional knowledge is very, very vital so that the patient doesn't end up with other side effects. So just to give a brief idea as to how we do these surgeries here. This is one of our patients who we operated recently has Parkinson's disease or Alicia's patients who do not really benefit from the dopamine after around 7 to 8 years. They go in for dopamine sensitivity where they have motor fluctuations. They have unwanted extra movements when the dopamine is given. And that is what our movement disorder specialist. This is one of the awake surgery that we perform, both lesioning and EVS we need the clinical outcome to be on the table so that we can modify our trajectories, we can modify where we are targeting. So as I said, we are playing with 8 millimeter room there. So there's less than a centimeter. If I fever, I was having the patient. So that is achieved by what is known as microelectrode recording. So this is the entire mechanical wire, but you can see that all that is going through. So I get the audio because you were able to make out those, small amplitude noise that happens. It's called thin on the rating on the thin roof. That terminology is used for the description of the noise that comes out. Those are actually the actual potentials that happens with the subthalamic nucleus. So we are at the neuronal level to map the subthalamic nucleus, and we want that signature, the electrical signature, to be our final element. There are no other technologies can help us. Even if we have an image guidance, they can be brain shaped. So we are employing this micro mapping to make sure that we are in the target that we would want to. And of course, our neuro specialists will tell us whether there is a clinical benefit or not. And this is the final placement. This actual electrode will be changed, where we reconstructed post-operatively to make sure that we are the target where we want it to be. So next, thalamus. This is another holy grail for our targets that we can achieve. There are various subgroup, nuclear subgroup that are connected. You can see that almost 2/3 of the brain is connected to the thalamus. And of course, this is a very, very important relay center when it comes to any of the functions of the brain. So briefly, in the cadaveric anatomy, you can see the thalamus, the floor of the lateral ventricle. And then, of course, the mesocerebral thalamus is in relation with the lateral wall of the ventricle. And the pulvinar of the thalamus is something again having a final surface in the quadrigeminal system. These are the only surface of the thalamus which is visible or which is accessible in an open surgery. But there are various group of subnuclei that can be targeted. That is very important for us to understand to aid in the treatment policy. So these are the vital diametrical structure. Just try to move it a bit to the slow video. So I just want to emphasize here based on the nucleus subgroups that are there in the thalamus. So as you see, it's a big group of nuclei. There are multiple nuclei that are really targeted for various surgeries. The two thalami are fused in the midline through interthalamic adhesion. So when we look at the each thalamus, you can see that there are various subgroups, and the terminology is pretty confusing if you look at it. But then this idea of putting this video is basically to understand that every single nucleus is being named based on its anatomical orientation. That's all it is. So if it is anterior, it is anterior nucleus. If it is ventral, it is ventral group of nuclei. From anterior to posterior, again, is anterior, lateral, and posterior. And then comes the medial dorsal nuclei, centromedian, and then the pulvinar. With two geniculate bodies, medial and lateral. So if you understand every single orientation of this structure, then it's easier to remember these nuclear subgroups. And for us, it is very vital that we know it. And thalamus is one structure which is entirely dependent on neurophysiological mapping. Basically, because you need a scientist like MRI to look at the nuclear subgroups. What we are doing clinically now is only 1.5% data. With which thalamus is just a big global base structure. We really can't report about this scientist MRI, which is largely a research-related MRI. It is not yet available for clinical application, but very soon next decade probably we will be using scientists. But now we are largely dependent on the physiological mapping that we do. Very important target for movement disorder is ventral intermediate nucleus, which is a very important nucleus comes in the ephemeral cell. There is, you see a terminology wise, brain nucleus is not seen in anatomists. So there is some mismatch. Basically, brain nucleus is the lateralmost and inferiormost part, the ventrolateral nucleus itself, that is being targeted for. This is the microelectrode mapping that I was talking about for tremor predominant disorders, like essential tremors, the tremor predominant Parkinson's disease, and that's how we do the MER. As you see in a suggestive orientation, as you go through the each and every group of nuclei, everything uses an electrical signature. And below is the somatotropic organization, where the hand is, where the legs are, where the patient can have abnormal sensation when we stimulate. So we know exactly where we are based on that signature. And this is the thalamus where we created a lesion using a radio frequency thermal coordination for the tremors. So this is another patient which we recently did a DBS for essential tremors. This is something known as articulated spiral, where you can see the high amplitude tremors coming in. Again, the initial patient where we inserted DBS, we did electrophysiological mapping, we found out where the tremor neurons are. Those spikes indicate tremors that are happening in the having group of neurons, and that is the electrical signature for the nucleus. But if you go a bit anterior to it, you get a very silent zone where ventral and anterior nucleus groups are. If you go a bit posterior, patient will start having hyperesthesia. Sensation which patient complains to us. So based on these, we figure out which target, where we are exactly, based on these features. Then we target that particular nucleus and then go in and put the electrode into that patient. Now you can see a phenomenal improvement of that tremor on table. Patients are the most happy on table itself when we can give this sort of result with these functional surgeries. And thanks to all the anatomists and of course the technological advances that have happened when the tremor stops on the table and we can achieve this. That's the final electrode which is passed to the 2.5 centimeter marble. That's all we have done to the right into the center of the brain. The electrode tip is in the center of the brain and we could achieve it through a 2.5 centimeter marble. That's it. So, and we have gone way ahead of that as well, where we can now pass the electrode through a 2 millimeter crystal course. That's the difference between which we can see on table. So that's about the briefly about movement disorders. I'll briefly touch upon 2 other functional disorders where the same basically targets are used. That is for epilepsy, drug refractory epilepsy, neuromotivation coming in a big way. When we know that we can target the nodal networks of functional epileptic network, when we really don't know where exactly the pathology is, MRI is absolutely normal. But when we do a video imaging, we know that there is a component of some focality. There are some perturbations in the frontotemporal networks. So we target what is known as anterior nucleus of thalamus for this particular problem, where we target through the transventricular route and approach the anterior nucleus of thalamus, because that forms the nodal center for all the frontotemporal circuitry. So that is actually a part of the circuit where it is right in the center, controlling all the frontal and central epileptic network. So, and this is also important to understand that this basal ganglia is separated from the cortical mantle in a very important surgical technique known as hemispherotomy, where we separate the basal ganglia structure from the cortex, preventing the epileptic seizures to pass down. I will wind up soon because we have lost timing. So I'll just briefly touch upon the various diseases that can be treated with these surgeries. Another important field where these targets are used is psychosurgeries. I think in West, it is day in and day out, they are operating various psychiatric maladies. But in India, it is taking some time, mainly because of the problems with policies, where we have very stringent guidelines for mental health disorder. But in summary, these are the very important targets that are used in psychosurgery, the cingulate guidance and the active limb of the internal capsule. So there's a big interplay of pathway circuit and limbic circuit. It's very important to understand these two circuitry because this is where we are targeting for obsessive compulsive disorder, major depressive disorder, and various substance abuse disorders. So how would the emotional anatomy look like? So whenever there is an environmental situation that is related to the amygdala, from there it goes to the sympathetic center in the hypothalamus, and you see various responses happening in person through the amygdalocerebral pathway, ventral amygdalocerebral pathway, and then through the medial forebrain bundles, the information is conveyed to the facial nuclei, and you see various facial expression of human anxiety. And when it goes to, it takes control by the control is taken over by the parasympathetic nuclear group from the same pathway which continues, and then a motivation behavior comes out. And then a person can decide whether it's fight or to fight or flight situation. It's very important that we understand this particular circuitry. In brief, I can tell you that it starts off with the hippocampus, goes through the fornix into the mammillary body. From there, the mammillary tract, and then it comes to the orbitofrontal cortex. Orbitofrontal cortex is the seat of various memories. In fact, I'm sure most of you might have heard about the Freeman, the famous psychiatrist who went around doing prefrontal lobotomy, dichotomy. That is basically done targeting the orbitofrontal cortex. Though it was overdone and with all sort of sepsis that has been happening, which is even called ice pick lobotomy, where you could use an ice pick to go through the orbital root to cut the frontal fibers. In fact, you guys would receive a Nobel Prize for prefrontal lobotomy. But gone are the days where such extensive surgeries are done. Psychosurgery took a lot of time to come back. Now it's a renaissance era for psychosurgery because of the advances. This is the real thing. These are not items. This is the real fiber that has been attached to but every single surface circuit or any complicated circuit that you want has been mapped. In fact, we're just discussing there is one close stage of connectivity where the functional areas of the brains are shown up on an image. So this is another limbic circuit which comes into role in psychosurgery that are happening. So the most important circuit that happens is from the cingulum. All the efferents happen. The outputs are to the striatum, and from the striatum, it comes to the anterior lip of internal capsule back to the orbitofrontal cortex. As I said, there is a modulation, similar to the motor circuit, there is a modulation for our own emotion. We can filter out the unwanted response. That is that becomes OCD, obsessive compulsive disorder. It's just an imbalance between these two where there is an imbalance between the singular input and the output from the anterior of the internal capsule. So when that happens, there is hyperactivity of the frontal cortex. And it's not as simple as I say, but then that is obviously the gist of it is that we do anterior capsule to target for OCDs, where the lesions are created in the anterior capsule. Into this striatum is taken care. Make sure that the patient loses his compulsion by controlling those outputs. And this is one of the cases which I had an opportunity to do at age when the patient had excessive compulsion of checking and washing hands. So we do something known as the scale. Based on his number of obsessive thoughts, number of compulsions, we do scoring known as Y-box scoring, which is an internationally accepted scale on which the score was 27. We did a robotic guided thermofibrillation at the anterior cingulate gyrus, where the lesions have been created precisely for the extent of 5 to 10 millimeter. And this is the postoperative image where you can see that lesion there in the cingulate gyrus, and the response was phenomenal within a month, where it came down to 56% of this obsessive compulsion. And the rest of it was taken care by the psychotherapy and the psychiatric drug. And my box score came from 24 to 12. So that's the era that we are in. So as I said, as compared to the lesion, there is also something on leverage stimulation for psychosurgery. And nucleus accumbens is one such target which is being used for OCDs and major depressive disorder, where the nucleus which I just described in the category approach That is being targeted for female stimulation for nuclear segments. And last target that we are still trying to understand is being invoked right now is the major depressive disorder target with medial forebrain bundle. A very important structure which has a huge role for emotion of pleasure. And whenever there is depression, you want to give the patient a pleasant sensation. This is the target that we're using. If you remember, I used this medial forebrain bundle when I spoke about the emotional pathway where the unpleasant sensations are taken, given to the sympathetic centers. So here is where we target. Using the diffusion pencil imaging, we can map now the medial forebrain bundle, and then immune stimulation target, when we use it, patient to benefit their depression. Immediately on table, a smile can be seen on patient's face. So that is the accounts that has moved ahead. So that's what the cybersecurity aspects. Thank you all.
Thank you, sir, for the wonderful session. Now I call Dr. Sneha and Prasad, Professor, Passive Medical College, Mangalore, to hand over the memento to Dr. Shabir.
We welcome you all for the fourth scientific session. We have with us Dr. Mukul Prati from NIMHANS, who is going to show us the cerebral section and overview of white fiber dissection. I now request Dr. Chaitanya Shetty to introduce him to the gathering.
Good afternoon to all delegates. Hope you enjoyed the lunch session. Yeah. It is my privilege to introduce our next guest speaker of the day, Dr. Mukul Prati, who is the Professor of Neurosurgery and Unit Head at NIMHANS, Bangalore. He completed his MBBS at SN Medical College, Agra in 1999 and pursued his MCH Neurosurgery in NIMHANS and completed it in the year 2006. He bagged 6 gold medals in his MBBS and was the class topper in the first MBBS. He has together 78 national and international publications to his credit. He has presented 38 papers in conferences, delivered 21 guest lectures. Later, he completed his fellowship program in microsurgical neuroanatomy in the year 2016 at Istanbul, Turkey, under Professor S.R. Gill, who is called the father of modern neurosurgery. He has been conducting workshops regularly on brain dissection and microvascular anastomosis, and he has keen interest in lab training using various animal and other models, especially with regards to microvascular anastomosis. Now I request respected Dr. Nupur sir to take over. Thank you, sir, for accepting our invitation.
Yes, all the delegates to kindly not record the videos what sir is showing.
Am I audible there? Yeah, thank you. So always a privilege to come to Ramaiah Hospital and Medical College. I sincerely thank Dr. Shalja and Sunil for having me here. I can't myself keep away from discussions on anatomy and neurosurgery. So anyway, I would have come if I was not invited maybe. So so it's been nice sitting here and enjoying the lectures which I have been listening. It was anatomical lectures, and it has been nice. I've learned a lot since morning. Now I'll discuss something with you. The topic is cerebellar dissection. Last 1 or 2 years, I've developed a habit. I give my conclusions in the beginning only, so you don't have to focus on the rest of the talk. And especially this being a post-lunch session, I'm going to give you the conclusion right in the next slide. It's a bit difficult to understand. And the conclusion is this. So how many of you know Indiana Jones movies? All of you must have seen, some of you must have seen. Can you raise your hands? How many have seen Indiana Jones movies? So all of you have seen almost. So Indiana Jones is a professor of archaeology, as all of you know. And most of the times he has something with him, some map or something, some treasure, and the villains are running after him. So in one of the scenes in one of the movies, he happens to run through a institute library. So he's running to the institute library, and one of the students who is studying in the library quickly asks him how to become a great archaeologist. So Indiana Jones says, and in his typical Hollywood style running manner, you want to become a good archaeologist? You have to get out of the library. First thing, when it comes to anatomy is not learned in the library. Anatomy is learned by 3Ds. I hope it has been told by our teachers, and I'll revise it for you. The 3Ds are dissection, foremost, dissection, discussion with your friends and your teachers and your tutors. And the last D is diagrams or photographs. These are the 3Ds in which you base your anatomy, and you don't learn anatomy in the library, definitely not. So with that, we start the topic, and this is my message to all of you. You are seriously interested in anatomy, you're seriously interested in becoming a good neurosurgeon or surgeon, you have to get out of the library, you have to get into the lab. What I learned in my MBBS days, usually in curriculums, we have very less dedicated time for neuroanatomy, and I was asking Dr. Shalja this question. The current batches get to spend around 2 weeks in neuroanatomy. So, which is, yes, less, but yes, they have a whole area, so many things to cover. But what I learned about, for example, for the internal capsule was this anatomy. And even a lot of us, including some surgeons, would remember this anatomy only. This like this. I never understood in my MBBS days, and even to large extent after I finished my MCH, what is this retrolentiform part of the internal capsule? What is sublentiform formator? I never understood till I started doing these dissections myself. That was 2.5 years after I passed my MCH. And this is one dissection which I have done. Fortunately, unfortunately, actually, this should be the image which should come to our mind when we talk about internal capsule. And this I have labeled. This is the anterior part. This is the genu. This is the posterior part, and this is the retrolentiform part, which is the. Now this makes sense. This diagram does not make sense, at least to me. Again, coming to the topic now, the deep cerebellar nuclei. Always, whether it comes as a physiology class or an anatomy class, we have been dealt with sections. Can we either imagine how without sections in gross anatomical specimens the deep nuclei cerebral peduncles will look? I started looking at literature in almost 9-10 years back. There was no literature. Either in anatomy or in neurosurgical textbooks, there is no literature that shows you how do these deep cerebral nuclei look. Other than sectional anatomy, there was no anatomy available. I'll take you to a bit of history now. In the 1840s, before the 1840s, everything was dissection.
You had to do dissection with your hand. Gross dissection was the only way to study anatomy. And those times there were no photographs also. Imagine. Everything had to be drawn with hand, like these beautiful figures. The left figure is by Wilbrand. But what happened? Something changed in the 1840s. Everyone used to learn anatomy by doing dissections, gross anatomy, by peeling layers, by seeing the tracks and all that, which was very good for your 3D understanding of that region. But what happened in the 1840s, something for good and something for bad, was that stilling. You can see here, stilling introduced the concept of sectional anatomy. And this is the sectional anatomy which he started, which clarified a lot of concepts. After sectional anatomy, we realized a lot of things which we understood wrong. And sectional anatomy clarified a lot of doubts. But the 3D understanding of the brain, of the anatomical structures, that to some extent suffered. As surgeons, we definitely need to understand the 3D anatomy. With sectional anatomy, it's difficult to comprehend. In 2000, Professor Ture and Professor Yasargal, with which I did fellowship, they published this paper, Fiber Dissection Technique of Lateral Aspect of the Brain. I know almost none of you would have heard the name of Professor Ure today. This article, whenever people even talk about brain dissection, this is the most commonly quoted article or referenced article. This was in 2000, and this, they say, revived the art of brain dissection, white matter dissection in the brain. All revolutions started after 2000, and it is after this article that the Roton group and everyone took over and started doing all those studies. What is there in the article? We will again come back to it in some time, but this was the article where the brain dissection, fiber dissection technique started. So let's come back to the cerebellum. There were some recent publications before I started to do this study. There was this very elegant study from the Roton group, but again the problem was the same. It had all sections. There's another study, Professor Evandro Oliveira, which me and Parche were discussing, and again the problem was the same. So they did not demonstrate all the deep nuclei. They resorted to sections at some or the other point. And most importantly, there's a basic problem in all anatomy articles, in almost all anatomy articles, that they do not give you a step-by-step dissection guide. They do not give you. They just tell you this is the view from this side, but how did you reach the view? They fail to tell you. But as students, we need to understand how to do the process of dissection. But just by seeing the figures, you cannot come to that level. So these are the study objectives in which we started. We never knew what we will end up with. When I met Professor Ture before the starting of my fellowship, and I said I want to work on cerebellum, he said only one thing: start. Where that thing will lead you, I also didn't know, and he also didn't know. What he believed was that the deep nuclei of the brain either cannot be dissected or will be very, very difficult to dissect. But that was the idea of the study, and to establish a proper method of dissection of the cerebellum by describing all the process in a step-by-step way, and to encourage the revival of pure fiber dissection studies in the cerebellum, and rather than the sectional studies, which all of us know. So we dissected 10 brains, in fact many brains, but for this study 10 brains, formalin fixed human cerebellums were taken. 5 were dissected from the superior surface, 5 from the inferior surface, and each step of dissection was described. And most importantly, dissection tools were very simple, not anything hi-fi. Handmade thin wooden spatulas with tips of various sizes, wooden toothpicks for very fine dissection of the nuclei. Suction and operating microscope. Operating microscope is very important for such dissection, as you will see, and you will realize the importance. So coming to results, dissection from the superior surface, I'll take you by layer of the cerebellum. We start from the superior surface first, and this is the surface view. Just for your understanding, this is called a simple lobule, but it's simply very simple. This is a quadrangular structure. This is called a quadrangular lobule. And then this is a superior semilunar lobule. This is your just a brief impression of the horizontal fissure coming on the superior surface. So as the first step, we just take out the simple lobule and the quadrangular lobule and tease it from a lateral to a medial direction. What do we see? We see some white matter there. Below the gray matter, there will be white matter. So you see here, we see some white matter here, and let's dissect this white matter further. In all the figures, you will see that this side will be one step behind this side. This side will be one step ahead, so that you can compare one step earlier to one step next. So it's a step-by-step dissection. So in this step, we have further dissected the white matter here, and you are seeing the peduncles already. This is the middle cerebellar peduncle. This you see is the superior cerebellar peduncle, and this, interestingly, on the superior surface is your inferior cerebellar peduncle. Honestly, I didn't know till I started these dissections. The inferior cerebellar peduncle, after coming here, comes to the hilus, or rather medial side of the middle cerebellar peduncle, and turns on the superior surface medially and ends up in the vermis. When you do further dissections of the white matter, you see that there is a bulge here, and this is the bulge of the dentate nucleus. When you dissect that bulge with the fine instruments which I told you, you see the gyrations, the tooth-like projections of the dentate nucleus, and here you are one step back, you see the white matter on the dentate nucleus intact, and here the dentations have been dissected. One step further, you see all the peduncles on both the sides. This is the inferior cerebellar peduncle, middle, this is the superior cerebellar peduncle, this is the vermis, and the dentate nucleus is seen on both the sides. When we peel the inferior cerebellar peduncle on one side, there is another tract going just below that. It's a very old tract, very primitive tract. It's called the fastigiobulbar tract, practically a part of the inferior cerebellar peduncle, but it is a distinctly separate. And now this is the fastigiobulbar tract on both sides, just covering the hilus of the dentate nucleus. And when we take out this fastigiobulbar tract on both the sides, you can see the continuity of the superior cerebellar peduncle with your dentate nucleus. This side fastigiobulbar tract is still intact. And this is the final picture. So when you take out the superior cerebellar lobule also, you realize that this is the depth of the horizontal fissure. Horizontal fissure is the largest fissure of the cerebellum. So the dentate nucleus is very closely related to the depth of the horizontal fissure. And just in case, if the functional neurosurgeons are willing to, there are people who are targeting dentate nucleus for various disorders, and this anatomy would be quite useful to them also. It's just there at the depth of dentate nucleus. In fact, one of my students, Dr. Nitish, recently submitted a thesis in which, in detail, we studied the relationship of the horizontal fissure with the dentate nucleus and middle cerebellar peduncle. So that's it. That was from the superior surface. Now, from the inferior surface, which is more relevant to neurosurgeons because most of the times we approach the cerebellum from the inferior surface. Very important. So again, this is the surface view. Just to tell you some of the functions, the surface anatomy. This is the tonsils. This is your gray side, and the next is the biventral lobule. And then this is your horizontal fissure. This is the superior semilunar lobule. This small is the inferior semilunar lobule. So in this case, we will take out the gracilis and the biventral lobule. As we have done that bilaterally. It's always good to understand anatomy from various directions. The same anatomy when we reach from the superior side, same anatomy when we reach from the inferior side, it gives you a much better understanding of that area. So the tonsil has been left intact, and now both the tonsils are gone. And if you see, there is one thin membrane here with some vessels going on, and that is the inferior medullary velum. When we take that out, we see a very, very interesting structure in the superior lateral recess of the fourth. This is the roof of the fourth ventricle, and this is the superior lateral part of the roof of the fourth ventricle. You see a bulge here and a bulge here. You will see that in much more detail. That is the bilateral dentate tubercle. It is the most lateral aspect of the dentate nucleus, which forms an indentation in the fourth ventricle. One of the few new things which came out from this study was that the dentate nucleus has got an intraventricular part and an extraventricular part. So this is the intraventricular part of the dentate nucleus. And just to zoom that, I have removed a little bit of ependyma from the dentate nucleus to show it clearly now. You can see on the right side, whereas the ependyma is still intact on the left side of the dentate tubercle. Now, both the sides, ependyma has been removed, and you see the bulge of the dentate nucleus in the fourth ventricle. It is there right in the fourth ventricle, the dentate nucleus. If we dissect the nucleus further, from that, right, starting from the dentate tubercle and come like this, it takes a shape of a U and comes, now this is the tonsil has been removed here. The tonsil is attached, the base of the tonsil is attached somewhere here, junction of the intra and extraventricular parts, and this is the extraventricular part of the dentate, and it comes right next to the pyramid. This structure of the vermis, so almost you can see the shape is like a pyramid, and it's called the pyramid. And again, there's a very interesting association of the pyramid and the dentate nucleus, which I'll show you again later in the practical aspects of the study. So again, highlighting the relationship between the pyramid of the vermis and the dentate. Just next to it, little bit you have to dissect and you will be on the dentate. Now both sides, dentate has been dissected right till the pyramid of the vermis. The pyramid is seen very nicely here now. What is medial to the pyramid is not the dentate now. It is the emboliform and globose nuclei. Nucleus interpositus now is coming into the picture now. And now we were going into uncharted territory. We had no reference, we had no guide where we are going now. But I kept finding gray matter, I just kept dissecting. And I kept going medially and medially. This is most probably the nucleus interpositus, and then the last pass, only the last part of the vermis is remaining, rest have been removed. The uvula has been removed, the pyramid has been removed, and the last part of the vermis is, as all of you know, is the nodule. This is the nodule here. And when we take out the nodule, we found an interesting thing, that is, we found again two small bulges in the roof of the fourth ventricle. Again, not described in literature before. And we slowly dissected the ependyma of the ventricle, of that bulge there, and we found a nucleus there. Same done on the opposite side, and we found another nucleus slightly bigger than the one on the other side. And this was the fastigial nucleus. Remember, when we started, we never thought we would reach till here. Sometimes we just have to start, and the rest will be taken care. But still, I was not sure what is this, because there's no reference. So all the ependyma has been pieced off. Now from the inferior surface, you are seeing the same structures, and you can see the relationship with all the structures. This is the superior cerebellar peduncle. This is your inferior cerebellar peduncle, and this is your middle cerebellar peduncle. So why do people don't do fiber dissection? What work you saw in 10-15 slides is work of 1.5 to 2 years in 15 slides. So why do people don't do fiber dissection, and why we resort? Because sections doing is very easy. And what Dr. Ture told in his paper is, because the fiber dissection technique is complicated and time consuming, its neglect was almost inevitable after the development of the microtome and histological techniques. Quite fair. A bit of history. This was the first view of the deep cerebellar nuclei. You can see this. This is a picture by Busen in 1641. Again, a sectional thing. This is the first view, first account of literature of the dentate nuclei available. Next was Viddair. And this was another corpus. He called this corpus dentale. Again, they used to draw, they didn't have photographs. The first book on cerebellum was written by this Italian scientist Vincenzo Malacarne. And he dissected the brain from all approaches. He gave far more accurate description of the cerebral cortex nuclei than any of his predecessors. But Stilling was the first one, and it was discovered on sections. All the nuclei were discovered on sections. Stilling was the first one. He was German. all the nuclei were described by Stilling in 1864 for the first time on sections. So as I told you, I had no idea what we found is the real fastigial nucleus or no. There was no proper dissection literature available to us. But as we know, there are several MRI atlases of the human cerebellar nuclei. Okay, and one of them was this article. And from this article, we realized that the position of the fastigial nucleus is right here and is almost the same as we have found out in our article. So this is the correlation to the MRI atlas, and hence we concluded that what we have dissected is the fastigial nucleus, as you can see here. Other microneurosurgical considerations, as I told you, it's very important to understand the relationship with the tonsil. As I told you, the tonsil base is right just after the dentate tubercle, the junction of the intraventricular and extraventricular parts of the dentate nucleus. The relationship with pyramid also I have shown you. The dentate is just next to it, and the surgeons in the audience will be knowing the region of the dentate nucleus very commonly is a very common site for cerebellar hypertensive hematomas. So this is one of the intraoperative picture here. As you can see, this is a large bulge in the vermis. This is your pyramid, and just next to it we have opened and found the hematoma, because the hematoma will always be in the region of the dentate nucleus. The study is not possible without the use of operating microscope, and this is also a contribution of Professor Ture to the technique of wide fibrometric dissection. The fine dissection is not possible without the use of operating microscope. And what do we use? We use wood instruments. Wood instruments, remember, all the musical instruments, the good quality musical instruments are always made of wood. The wood dissection instruments are better than the metal dissection instruments, because the wood gives you a much better tactile feedback, and then we can do this fine dissection. So conclusion, the complex structure of cerebellum can be more clearly defined and understood by the wide fiber dissection technique. To the best of our knowledge, this was the first study demonstrating step-by-step dissection of the cerebellum using this technique. Fiber dissection is time-consuming and complex, but it greatly adds to our knowledge of brain anatomic features and thus helps improve the quality of microneurosurgery. This is the publication which we did in 2020 in Operative Neurosurgery. It's a very good journal. He's my mentor, Professor Ture. I met him last in San Francisco in the CNS. He's regarded by Professor Yasargil. Professor Yasargil is the father of modern microneurosurgery, and he is regarded by Professor Yasargil as the finest microneurosurgeon of the current era. He spent 5 years, please mind my words. He spent 5 years in anatomical laboratories across the world at the prime of his age. 5 years. He didn't bother about money. He didn't bother about other things, but he spent 5 years in the lab, only in the lab, not in the OR. That is the answer to Parche. You had a doubt regarding the time spent in the lab. This man spent 5 years in the lab. And still, whenever he has an opportunity, he will come to the lab and guide students like us. Thank you very much. So I have a small video here because both Madam and Sunil asked me to show you. If you have time, how much time here? Yeah. So we'll go to the video. So in this video,
Surface neurosurgery, brain and spine tumors. Sir has received numerous best paper presentation awards in various neurosurgery conferences. He has presented 36 unique and rare neurosurgical cases in various scientific meetings, and sir has around 82 research papers published in various peer-reviewed national and international journals. Sir is constantly involved in conducting cadaveric and operative workshop on craniovertebral junction surgery and microvascular neurosurgery and wide fiber dissection course at cadaveric skill lab. Apart from other regional memberships, he is also a member of American Association of Neurosurgeons. We welcome you, sir.
Thank you, one and all. Really an honor and privilege to be here. Really an honor and privilege to be here for this August gathering. My talk will be basically on the applied aspects of neurovascular anatomy. So there will be a little bit of dissection pictures which are incorporated, but most of them will be operative videos.
and there will be some journal publications which also are shown along with the slides. So without wasting much time, let's start with the presentation. So this is what we usually see in the anatomy dissection lab. The dissection of the carotid artery, that's how we start off with the head and neck. As you can see here, we see the various branches, the occipital, the posterior auricular, social temporal, which is coming from here. Then you have the ascending pharyngeal, which is very important when you do endovascular procedures, and various other branches. And if you study the same picture using an angiogram, you have a better idea of how these vessels are oriented. Coming to the pathology, I just start off here. There's nothing much to variously describe. As you know, the cervical internal carotid artery doesn't have any branches, so there's nothing much to describe here, other than the fact that you can have carotid stenosis, which you can treat in various methods. You can either, if you're skilled enough, you can do a stenting for this region, or if you are a hardcore neurosurgeon, you can open the carotid artery, remove the plaque. What you can see here is the plaque, and then remove the entire plaque and suture the vessel back. What is important here is to study the development of the carotid artery system. That gives you a very idea of how various anomalies can develop and how various alterations and various changes in the anatomical orientation, the vascular orientation, can occur in this region. So if you see here around the 3 to 4 millimeter fetus, you have the various branchial arches being formed. What is important here is the third branchial arch and a small twig which comes out from the uppermost part, that's the first branchial arch. So as these areas regress, you have the part from the second branchial arch giving rise to this area called the ventral pharyngeal trunk. The ventral pharyngeal trunk gives rise to most of the external carotid branches. And as we have to respect our ancestors, pathology follows phylogeny. We have to see how these have evolved. And at this point in time, the posterior circulation is dependent a lot on the anterior circulation to get its blood supply, which can supply the major part of the hindbrain which is developing. So to summarize here, you have the uppermost twig giving rise to two divisions, a caudal division and a cranial division. And then you have all these primitive vessels which can give rise to the primitive maxillary, the trigeminal artery, the hyoid, mandibular, otic, the hypoglossal, and the pro-atlantal artery in this region. So if you see the ICA developed from all these, you'll have remnants of all these incorporated as the vessels, as the embryo develops, as the fetus develops. And all these various structures get incorporated into the ICA, and this will be the ICA, and this area would be the external carotid artery, and the part which is from here would be the common carotid artery. So let's see some anomalies in this region. This is the most common anomaly that we see. This is called the persistent trigeminal artery. So this is seen in about 1% of individuals. You can see that the persistent trigeminal artery can go right from the petrous part. This is the petrous part of the ICA. It goes all the way back across the floor of the fossa, the middle cranial fossa, close relation to the second and third cranial nerve, and joins the basilar artery. So whenever you have these structures and angles to each other, you can have certain pathologies which can develop, like aneurysms. So there's a high incidence of having aneurysm along the trigeminal artery, and where the trigeminal artery, persistent trigeminal artery, joins the basilar artery. This is one paper which I published during my stay in Satyasai Hospital. This is another rare anomaly. As I told you, you also can have the hypoglossal artery. The hypoglossal artery is here. So if that is a remnant, so what happens is, as I told you, these are ICA to intracranial, ICA to posterior circulation communications. So you have the ICA. This is an ICA injection for all those. This is an ICA injection, and through the ICA, you can see that the lower part of the vertebrobasilar artery is filling. So what has happened here is, This is the hypoglossal canal. So through the hypoglossal canal, you only have the hypoglossal nerve going through it. But here you have an artery connection coming from the ICA, going through the hypoglossal canal and joining the vertebrobasilar system. So this is an abnormal connection which is not there. So there's a high flow of jet there. And this patient developed an aneurysm at the point where it joined. And the patient had aneurysm at that junction. So that was clipped successfully. So the other anomaly that can occur, as I told you, this structure comes from the external carotid system, forms the external carotid system. This forms the internal carotid system, and all these, the longitudinal venous arterial channel which is being formed in the region of the hindbrain, give rise to the upper part of the vertebral and the basilar system. So if there is any problem here, which this part, that is the persistent primitive proatlantal artery, suppose it doesn't get involuted, so that has a connection with the occipital artery. Okay? So the occipital artery would form here. As it involutes, it gets adjusted into the ventral pharyngeal arch. So if this persists and this part is not developed well, so what happens is you have the V1, V2, that is the vertebral artery which has developed in the neck. Along with that, it has the persistence of this primitive system which is connected and gives rise to the occipital artery. That goes and connects to the external carotid system. So what you see here is the posterior circulation, occipital artery. The occipital artery here is reforming the entire ECA. Okay, so that is another anomaly which we have noticed and published. This is where it was published recently. Okay. Sometimes you can have the ICAs not developed at all if the branchial arches, the third branchial arch and the primitive ICA which is developed is not formed at all, then you won't have an ICA at all. So here, as you see, there is no carotid canal. There is no carotid canal here. So what you see, in fact, here is the ECA. And through all these anastomosis, which I'll be talking about in the few next slides, you have the ECA forming anastomosis with all the small cavernous branches of the ICA. They could be dural, they could be branches from the cavernous segment of the ICA, which I'll discuss. So these are reformed in a primitive developing embryo, and what you see here is just the external carotid artery giving rise to the and supplying the and reforming the internal carotid artery. So this is what neurosurgeons and neurosurgery residents always go through in their exams. They always ask the classification system. The one which we usually follow in neurosurgery is this system by Guthelier. Okay, we finished C1. Now let's go to the other sections. In the C2, that is in the petrous part, there are two branches which can come out. They are usually not seen. The two branches, one is the median artery and the other one is the caroticotympani. These usually are not seen unless there's a pathology. A pathology is when there is a glomus tumor in the middle ear, or if there is an arteriovenous malformation that you can see there. Otherwise, these vessels are not seen. Most of the vessels in the petrous and in the cavernous sinus are not usually seen unless there is a pathology which enlightens them or there is a block which opens up these channels. What is important here to see is there is a vertical part here to the petrous. This is a section where the patient is lying flat. So this part would be inferior, this would be superior. So here you have the vertical or the horizontal part and the vertical part and the horizontal part of the petrous segment of the internal carotid artery. Okay. What is important here for a neurosurgeon is to identify this nerve, because this is very important to identify when you're trying to drill into the middle fossa, and that gives you the direction of the GSP, and that is the greater superficial petrosal nerve. Will usually give you the orientation of the ICA underneath the bone. Then comes a very important area which has a lot of prime real estate value, that is the cavernous sinus. Cavernous sinus is actually covered by a lot of membranes which I'll not talk about. I'll just talk about the vascular part of it. So these pictures I've taken from the manual by Roten. I'll discuss that separately towards the end. So the ICA in the cavernous region has various turns and genues, like they say. First you have the ascenic part, then the genu here, the horizontal part, and then you have another genu here, and then the anterior part, and then the subclavian part. Okay. So there are various branches in this region. One is the inferior lateral trunk. Inferior lateral trunk is here. It gives rise to blood supply to the cavernous sinus, to the dura, to the V1, V2, to the V2 and V3 nerve. And then you have a very important branch here called the meningohypophyseal trunk. Meningohypophyseal trunk, as the name suggests, there's an inferior hypophyseal branch. And there are two branches which go posteriorly. As you see, this is the tent. So obviously it's the tentorial artery. For those who like quizzes, it's called the tentorial artery of Wernicke and Centenary. So again, these are not very seen usually. Usually seen when there's a pathology, as I'll show you next. And there is another branch which goes down this way, which is the dorsal meningeal branch. So dorsal meningeal branch would supply V1, V2, and in the region, all the structures in the region of the doraloscan. And the tentorial artery would supply, of course, the tentorial region here and also the region around the clivus. As I told you, these vessels are not usually seen. They're usually seen when you have a pathology like hemangioma, when you have a pathology like cavernous sinus meningioma. So these structures derive blood supply from here, and that's when you have these branches from the cavernous segment of the ICA lighting. Some pathology here, as you see, there's this a structure here where you have an arterial system and a closed, loose channeled venous system, which is just held together by various fibrous structures. So whenever there's an injury, suppose a person has a road traffic accident, or if the person has developed an aneurysm and the aneurysm ruptures, so you have a direct communication between the carotid artery system and the venous system. So it's called a caroticocavernous fistula. This is one picture of a person with a carotid-cavernous fistula. There is a huge venous back pressure because there is the superior ophthalmic vein, which also drains into the sinus, is dilated, and the person will have proptosis. The person can have chemosis. So this is how it is, and what we have done is we have sealed off the entire fistula by using a lot of coils and glue. And though the person has stenosis, that's not going to improve. We have taken care of the chemosis. So earlier there were a lot of methods of dissecting into the cavernous sinus. There are various triangles, but with the advent of either radiosurgery or bypass surgery or the advent of flow diverters, approaches to cavernous sinus has gone down, and we have a lot of advancements like flow diverter placements. Here you can see a large aneurysm in the cavernous segment extending into the supraclavicular region, and we can, instead of going into the sinus and either doing a bypass or trying to get to the cavernous aneurysm directly, we can put a flow diverter to these structures and then reduce or shrink the aneurysm over 3 to 6 months. So the next structure would be the clinodal segment. So we finish the cavernous, then comes the clinodal segment. So here, what we have here is a layer of dura. This is the clinoid process which has been removed. So there is a layer of dura which covers this region, goes over the optic nerve, over the diaphragm, and over the tuberculum dorsum cellular region. Here it splits into two. The lower part is called the proximal dural ring, and the distal part is called the distal dural ring. These rings are kind of flabby and separate. They only unite posteriorly. So the area between these two rings of dura is called the clinodal segment. What is important here is, because some aneurysms are very difficult to approach unless because there's a lot of bone involved, there's a lot of fibrous structure in the form of dura which is involved. So what we tend to do is we need to drill. These images again demonstrate the carotid cave. This is a structure which is there in the part of the, see the previous here. This is the area here which is called the carotid cave. So these images I'd like to acknowledge Dr. A.S. Hegde. These pictures were taken by him during his stay, his fellowship in Japan, and he has voluminous research and publications on the carotid cave region. So this is nothing but the two layers of the dura which separate from the clinodal segment here. Here you have the distal dural ring and the proximal dural. These unite behind here, but there is a potential space here which is filled with subarachnoid space. So that is area which is called the carotid cave. So this is medial, this is lateral, this is the carotid cave, they have the optic nerve here. This area is called the optic strut. Optic strut separates the optic canal from the superior orbital vision. So the boundaries of the carotid cave would be the medial border of the sphenoid bone. Laterally you have the ICA, then you have the optic strut, and this area would directly drain into the subarachnoid space. So even though the aneurysm may look like to be in the cavernous sinus, actually it's in the subarachnoid space. There's a high chance of it being in the subarachnoid space, and it can cause subarachnoid hemorrhage. Can anyone identify this vessel here? This is your ophthalmic artery. This is the cavernous part, so it's the supraclinoid part. So it is going medially under the second nerve. This is the superior hypophyseal artery. Okay? That's the superior hypophyseal artery. So coming to some pathologies which I will demonstrate in the form of videos. As you know, the circle of Willis is a very nice to draw it. Inderveer Singh Chaurasia will have a very nice diagram, but it is not what it is. It's totally different. It has a lot of variations. As you see, there are a lot of variations and how these structures can develop. And whenever there's a variation, there is an acute angle. Whenever there's an acute angle, there is a force object acting on it. And these areas can potentially develop aneurysms. So, as I told you, I showed you the anterior clinoid process. This is a publication which we had worked out myself and Dr. Narayan from Centenary when we were working there. We, of course, worked on the bone first, and then there were no cadavers there. And then we demonstrated on how to remove the dura and drill the bone. And I will show you, these are the pictures which we drew ourselves. And this is one case, and I'll let the video speak for itself.
The first case is the facility of a medially directed right ophthalmic segment aneurysm. The aneurysm is approached through a right diagonal craniotomy. The dural flap, which is raised posteriorly, is cut with a 15 number of braided knife. The flap extends from the medial margin of the optic canal to the lateral margin of the anterior carotid process. The flap is situated with a flat dissector. The reflected flap covers the internal carotid artery, the aneurysm, and the optic nerve. The optic canal is then unrolled with a 1 mm keratin sponge, starting from the posterior free margin of the roof of the optic canal. The foot plate of the keratin sponge is introduced between the roof of the optic canal and the optic nerve sheath. The surrounding structures near the area of drilling are covered with wet gel foam pieces. The anterior canal process and optic strut are drilled with 1 or 2 mm diamond drill bits, and a part of the anterior canal process is removed with a 1 mm of keratin sponge. The thin shepherd bone which remains is broken with a flat dissector and removed. The falciform process and the optic nerve sheath are cut with micro scissors. The distal dural brain is then cut. Proximal neck is identified after mobilization of the optic nerve medially. The ophthalmic artery is identified medial to the neck of the aneurysm. The aneurysm is then clipped with an angle clip after the application of temporary clamp on the cervical internal carotid artery.
This is another picture I want to know, but what I want to demonstrate here is that same technique has been used again, and we have reform the ICA using these special clips so that we both get to the aneurysm and also allow blood to flow into the intervening circulation for this ICA. Clips are called penetrated clips. So the On the distal end, they hold the aneurysm and because of the opening there, they maintain the patency of the internal canula. Nowadays, we don't have to do all this. We have the advent of coiling. So a lot of work, a lot of drilling, a lot of morbidity, a lot of mortality also has come down. We can, this is another ophthalmic segment aneurysm. What we have done is placed a balloon here, pushed in a lot of coils from inside. Big work of drilling, chance of rupture of the aneurysm. So, what is important here is what I showed you initially is something called the anastomosis. A lot of anastomosis in this region, right, from any vessel which is there, the internal maxillary artery, the ascending pharyngeal, branches from the temporal, branches from the middle meningeal front, which is again a branch from the then can form anastomosis. So this patient had undergone radiosurgery for vestibular swelling. And you can see here there is no filling of the internal pharyngeal artery on TSA. What is important to see here is to have reconstitution of, this is the ICA. We have reconstitution of the ICA from the ascending pharyngeal, from the deep temporal branches of the internal maxillary. We have feeders from the middle meningeal artery. You have retrograde filling from the ophthalmic artery, and you also have filling coming from the neurovascular branch of the ascending pharyngeal, the ICA. So these are all the anastomosis which are there in the skull base, at the base of the skull, which connect the ECA to the ICA in the cavernous region. Another important thing which a neurosurgeon should also keep in mind is the distance between the two carotid arteries. If one does an endoscopy, one can see that the carotids are very close to each other, and sometimes they can be almost kissing each other. So there's a high chance of injury while doing an endoscopic procedure. So this is one case where I had an endoscopic, where I had an injury of the ICA and recurrent operated pituitary adenoma. The distance was 1.7. The tissue planes were lost because it was a recurrent case, and I had to actually from the endonasal root into the superior sinus pack that area with muscle and glue. And then, luckily for me, there was a very good circulation which was supporting it from the posterior circulation, the posterior communication. I hope the patient and I was safe. Can someone identify this? This is actually a horizontal A1 segment of the anterior cerebral artery. Usually the A1, the ACA will come up from here, very close to the bifurcation from the MCA. But this is more proximal, it is horizontal. And what you can see here is, usually all of us see the anterior cerebral artery above, on the line on the optic apparatus. But here it is intra-optic. So it is coming directly from the ICA. This is actually going towards to form the MCA. So it is under the ICA, under the optic nerve, and this is the A1 segment. And this is the other side, A1, which is coming and joining it. So this is the intra-optic anterior A1 segment of the anterior cerebral. So this is how the picture is when you see the blood vessels coming into the central thyroid region. So these images are actually drawn by hand by a very famous neurosurgeon from Japan. He had the habit, as Dr. Nupur said, the 3 days one is to draw. He had the habit of drawing all pictures, all images, all operative images of his vascular surgery. And this is one of his images he has drawn. So this is not always like this when we see in the operative room. It's not so clear. It is not like having classical music. It's more like rock music. When you're trying to separate the structures which are attached to the brain, you're trying to open the arachnoid, which is kind of inflamed and also stuck because of the bleed. So here you see this is the anterior, this is the frontal lobe. So this is one ACA, this is the other ACA. This is the anterior communicating region. This is the A2 on this side, this is the A2 on the other. So this is how it looks when we see the anterior cerebral artery under under the microscope. So I just briefly mentioned the types of circulation in the anterior cerebral region. Type 1 circulation is when the aneurysm, we have an aneurysm which fills from ipsilateral injection, and the opposite side is also seen but not filling the aneurysm. The type 2 circulation is when the aneurysm is filling from both sides of the injections, from the left or the right side. The type 3 circulation, you have the aneurysm filling only on one injection, and the other A1 is hypoplastic or aplastic. And the type 4 circulation, nothing but a type 3 circulation, but here you have a fetal ECA. Why this is very important is, when you plan your surgery, you should know which side to approach the aneurysm from. If you approach the aneurysm from a side which is not filling, then obviously if there is an intraoperative catastrophe like rupture, then you will find it very difficult to have proximal control on the ACA. So I'll show you some various projections of the aneurysms here. This is an anterior projection. So this is the ACA, this is the AFib region, this is the aneurysm here. So the aneurysm is projecting anteriorly, aneurysm is clipped. We have a posterior projection where the aneurysm is directed backwards. This is where the aneurysm is here. Third, we can have is a superior projection where the aneurysm is directed superiorly. In these cases, what we have to do is remove a little bit of the gyrus rectus to identify the aneurysm, because it's directed upwards, very difficult to identify the neck of the aneurysm. So this is the superior projection, and the aneurysm being clipped there. Then you have an inferior projection where it is directed anterior inferiorly. This is the optic nerve. This is the other optic nerve. So between them, the aneurysm is projecting. And the aneurysm is clipped. So I showed you the 4 different projections of the possible anterior cerebral, anterior communicating. As I also mentioned, where you can clip, you can also coil. So you can put a stent and also coil this without going through all this procedure of opening the skull. The other location where you can have aneurysms is the distal anterior cerebral artery. This is again very unique structural area, because here you have the box in between. So you have a very high chance of having aneurysm because of trauma, and also very high chance of having aneurysm because there are so many branches which are coming out. So approaching these aneurysms also can be a challenge because of a lot of veins which are there on the medial surface of the brain. So trying to get to the aneurysm, there's high chance of injury. The patient can have something called the SMA syndrome. The patient can have a retraction or venous infarction. And sometimes it will be just because of the small location of the small corridor, it will be very difficult to identify that. So another area where you can have an aneurysm is on the ICA now. So we finished the ACA region, DACA. Now we come to the main ICA. So this is the posterior communicating segment. So a large nice aneurysm which is there pointing. Can be easily, this is the optic nerve on one side, optic nerve on the other side. This is the optic chiasm. This is the ACA. So easy to clip these, you have it. Here you have 2 aneurysms. Here you have aneurysm on the posterior communicating and the choroidal artery, the choroidal segment. So there are 2 aneurysms which we coiled. This is something which we all need to see. Sometimes hell can break loose when you're operating, and there having a knowledge of the anatomy preoperatively can be helpful. So usually a rupture can occur here when the vessel, when you try to manipulate the aneurysm, either because you're overconfident or you've not studied the anatomy as well as you should have, and you probably thought you could get away pretty early. But once it bleeds, it can be a catastrophe because everything is on a high, your adrenaline is pumping, the heart rate goes up. The only person who can help you out at that time is your assistant, because he's the one who is calm, and you're the one who's trying to save your skin and the patient's life, because aneurysm is ruptured. How much of cotton will not help? So the only way you can try to do this is to. So this is the bleeding which can occur at 120 millimeters of mercury. What you need to do at this point in time is to apply clips. We apply clips on the ICA proximal to the aneurysm, and I also applied a clip distal to the aneurysm, but that did not help much because this is a communication segment. So there is some blood which is already linked from the posterior circulation. But whatever helps will help. After the bleeding has been controlled, everybody calms down a bit, and then you start applying clips. This is more of a salvage because there's no way you can try to dissect the aneurysm now. The only way is to try and control the bleeding by applying clips. So you take the clip from here and apply it on the aneurysm when it's still bleeding. Then you apply one more and no amount of coagulation will stop it. The only other way you can do is to apply one more clip. This is a posterior communicating artery aneurysm. So this is towards the base. It's lateral. Then the proof of the pudding is to try and remove this clip to see whether it bleeds after that. And if it's stops bleeding, then you can live to tell the truth. So the other aneurysms you can have are in the middle cerebral artery. These are mostly usually clipped because these there's a lot of variation. You can have trifurcation, you can have bifurcation, you can have incorporation of the vessel into the neck, into the aneurysm dome. So trying to coil it with a wide neck that's so distally in the anterior circulation is difficult. So it's better you try to clip these. Some aneurysms in the posterior circulation. This is a P1 segment aneurysm which we approached from supratentorial. This is the optic nerve, this is the ICA. So lateral to the ICA, this is a P1 segment aneurysm which has been approached and clipped. This will be the basilar there, see here. This is aneurysm clipped. You have P2 segment aneurysm. Here you will have to open into the avian system. So the tent has been cut, it has been pulled anteriorly. This is the aneurysm here. Then you have posterior circulation aneurysms. Pica has 5 segments. So proximal pica aneurysms can be clipped distally. Usually they are dissecting aneurysms. You may have to sacrifice the vessel. So this is a pica aneurysm which is clipped. Here you have to dodge between all these lower cranial nerves which are seen there. The pica, as you know, will be closely related to the lower cranial nerve. You have to prevent any injury to these while you're clipping. The other aneurysm, this is the basilar. So you have a dissecting aneurysm, you cannot clip it. So what you can do is put a stent in these cases. So as I told you earlier, you have the development of the posterior circulation from the mesoderm and the neural crest. So at that junction, there is a V3 segment, V1, V2, V3, V4 for the vertebrae. At that junction, what can happen is the mesodermal neuroectodermal junction is there, and that is prone to a lot of dissection. And you can have a dissection and bleed, and you can have something called a vertebral fistula. This is very nice in the sense this video was made 21 years ago. I was doing my residency, and this is actually a mycotic aneurysm. Any infection can spread through the blood, and that the infection can be carried from the blood into the intravenous circulation, or the infection can come from within into the blood vessels, like the patient is having pulmonary meningitis, or the patient is having tuberculous meningitis. So these aneurysms are either distally placed or very small. So it was very difficult to identify it in 2003. So what we did was we used stereotachy to focus on where the aneurysm is, and then after that we found out where the exact location of the aneurysm, and then the small section of AVMs. AVMs are hematomas. Hematomas are, as you know, abnormally organized neural vasculature in a normal location. So these are how they look like. A lot of This is the area which has been staged in the sense first we embolized it, and after embolizing it, we reduce the blood flow and then excise it. But a lot of management of AVMs has changed now. Earlier, when I was doing my residency, any AVM everybody used to pounce and get it operated. But now there was a study which is called come out called the October trial, which says that if the aneurysm is asymptomatic, the aneurysm, if the AVM is asymptomatic, if the AVM is causing only seizures which can be well controlled with medication, then do no harm. Try to treat it medically rather than trying to get it operated or trying to get it endovascularly treated or orthopedic. So another mythology here, we've always mentioned about the dura. Sometimes the dural venous structures can get blocked, and when they get blocked, they try to release a lot of angiogenic factors, and these angiogenic factors derive a lot of blood supply from the dural supply, and they drain into the venous system, into the large venous sinuses, and then you develop something called a dural aortic fistula. There are 5 types of classification of dural, which I'm not going to it. So it's very simple to identify. You have the middle meningeal artery, the posterior branch, which is supplying the fistula here. Here again, posterior temporal artery, which is going upwards and supplying the superior sagittal sinus. And what we see here is because of the increased blood supply from the external to the internal circulation to the venous system, there is venous hypertension. This is a typical picture of a person with venous hypertension. And if you do a fundus examination, it's 100% assured that the person will have bleeding. So the only way to treat it is to treat it endovascularly. We go through all these branches and inject them with material like onyx or squid or even glue, and then we seal up all the connections so that the abdominal connection is lost. The other thing you can see is a spinal dural aortic fistula. They go through all the radicular branches and supply the structures which are going through the radicle. You can have blood vessel loops which are very close proximity to the nerves. This is called a neurovascular conflict. You can have trigeminal neuralgia, you can have prefacial spasm. So this is a conflict between the 7th cranial nerve and a branch from the SCA. This is the basilar artery there. So what we can do is either put Teflon and fix it there. This is a lady who has severe prefacial spasm because of the neurovascular conflict. Since there is an ectatic vessel, just putting Teflon will not help. So what we did here in this case was we made a sling of dura and attached tied up the vessel, pushed it away from the 7th cranial nerve, and then attached that using a sling to the petrous part of the dura on the petrous part of the temporal lobe. And this is how she is after the procedure. A small picture on bypass. So this is how we have various procedures which we can do. The superficial, there are various conditions like Neuroanatomy disease, or earlier they used to do it for atherosclerosis, but mostly given up now. Wherein you identify the STA and then open the dura and open the arachnoid. All this is arachnoid, which is usually lost with the formalin. Identify the MCA recipient, and then using 10-0, which material which is smaller than the dimension of the head, we anastomose the superficial temporal artery to the middle cerebral artery to establish blood supply. So this is the dimension of the vessels. Usually it's less. This is a millimeter scale, usually less than a millimeter. And this is how the vasculature is established. This is the STA which is feeding the anterior circulation through the anastomosis. Sometimes you cannot do a direct bypass, or sometimes you've already done enough bypass, but still the blood supply is not enough. Then you use something which all of you know, which is the policeman of the abdomen, that is your omentum, and you tie the omentum, take it out, and place it on the brain, and It's actually an angiogram, but the angiogram is done from the abdomen. This is the supramesenteric angiogram, which shows the blood supply going along the supramesenteric artery to the middle and supplying the brain. There are some articles which are. This is one area which is totally neglected. Nobody talks about the brain venous system, because usually collapses once you put formalin. Very difficult to identify. But my teacher and a lot of my guides used to tell me that never neglect the venous system. You can coagulate the arterial system, it can show a stroke, it can develop some biocollaterals. But you're trying to coagulate the venous system, it can be unforgiving, especially if it causes venous hypertension, especially if it causes a hemorrhagic venous. So this is the supracerebral sinus, infracerebral sinus. So this is how it is in an angiogram. You have the basal vein of Rosenthal, the internal cerebral vein, the gate vein of Gallant. Here you have the infracerebral sinus is very small. You have the straight sinus going up to the torculum, and then you have the transverse and the sigmoid sinus. Sometimes this is how a venous infarct looks. We have once seen it during surgery. Sometimes there is retraction, inherently and evidently the vein snaps when you coagulate. So sometimes if the venous system can get occluded, and you can try to remove the clots and then open up the system and probably prevent the patient from having a lot of deficits. The last talk is about stroke. It's only 2 slides. What is very important is however much you open up the blood supply, you have an MCA which is blocked. What actually helps maintain the blood or maintain the brain is all these pile collaterals which come from the ACA or from the BCA. So we all know that it's an end organ. We all studied that there is no connection, but actually, why do patients survive 6 to 9 hours before you do a thrombectomy? It's all because of this luxuriant perfusion which you get from the area which is not blocked. It supplies the middle cerebral and posterior cerebral. So this is our department. This picture needs to be updated. We have more additions to the department now. This is how I started off studying anatomy. A lot of expectations started off with Gray's Anatomy. But then it was very difficult to retain everything in the first few years. So this became a book to keep other books on. And then we read Neurosurgery. We did very well. I mean, it's a very good book. It helped us pass the exam. And but what I would request all of you, those who are interested in neuroanatomy, as Dr. Tulen has helped in mitral dissection, I would consider this person to be the father of the neuroanatomical dissection. That he has come up with various volumes, the supratemporal and intratemporal anatomy. These are available on the net. Most of us have free copies which we have downloaded for spaces. It's very good, very informative, it's exhaustive. You'll have every vessel which is required to be described, discussed in detail, and he is probably devoted. He's a neurosurgeon, and he has devoted his life to the study of the neuroanatomy, not only vasculature, but the cerebrum, posterior fossa, the cavernous sinus. So please, if you are interested in neuroanatomy, try to read this. Thank you.
Thank you, sir, for that interesting session, much needed for anatomy studies for students who apply neurovascular anatomy. Now, I request Dr. Vishal Kumar, Professor and Head at Federal Institute of Medical Sciences, Neurosurgery, to hand over the memento to Dr. Thank you, Dr. Vidya. Now we've come to the end of the scientific sessions, and I would request any one of the delegates to kindly share their opinion about the session, about the field. So please, Dr. Prakash, sir, please, Professor and Head, Department of Anatomy from Harvard Institute of Medical Science.
It was very nice, enriching, plenty of three-dimensional and the active cases, which we think, our anatomist anatomy has been cross-sectional anatomy. That's what we got to know. Even though we feel, okay, what is there, we don't have much, but since morning to evening, all the speakers gave us information, and it was, there is still more to learn. So that's what we could sense. Hope it was, it's very nice. Hope everyone will agree with me. Thank you very much.
We also have Dr. Uttara Suri, Professor and Head from Akash Institute of Medical Sciences. Meanwhile, I request all the delegates to also fill up the feedback form that is provided in the registration kit. Good evening to all of you. As I would say, special thanks to the organizing committee with lead by Dr. Sharada Shettiman for organizing such an academic feast to us. It was an enriching experience. We refreshing our knowledge by Dr. Pratap and Dr. Yogesh to that of the neurosurgical aspect. Yes, the evaluations by Shabin sir was fascinating, and in fact, we got a new perspective to how a basic diagram looks. The entrance diagram gave a different outlook to us. It was as tasty as the food. Academic piece was as tasty as food. And in our school, it was a fantastic measures of fiber optic dissection of the cerebellum. It gave me a nostalgic experience. Be it me or Dr. Pratap, we had tried out this technique in our postgraduate time. We have dissected the association fibers, and of course, we could reach till the sublimity form part of internal capsule. Yes, if you would have used wooden instruments, probably the electrolytic form part of the internal capsule would have been dissected. And thank you. This reminds me of that neurosurgical atlas by Indiana University. It's the largest collection of atlas, microsurgical, images of the neurosurgery and surgical anatomy. And this definitely deserves a place in that collection. Thank you so much for these amazing photographs. And last but not least, neurovascular anatomy is coming. Yes, as anatomists, we never considered a small horizontal part of anterior activity is so significant. But from a clinical aspect of it, yes, it definitely matters. So thank you for such an academic piece. Thank you all very much. Thank you, Dr. Ruchitaman, and also Dr. Prakash. I call upon Dr. Shivakumar sir. Sir wants to make an announcement regarding the conference.
So the 22nd Karnataka chapter of Anatomy Conference 2022. So it's being hosted by Department of Anatomy, Assam Institute of Medical Sciences, Assam. Invite each one of you, please register yourself and actively participate so that we will have a time to get together, but at the same time try to exchange views and opinions. Thank you very much. September 16, 17, 18. Friday, Saturday, Sunday.
Good evening, all. It was a wonderful CME. I would like to thank Dr. Shailendra Madam and the entire team for arranging such a wonderful CME. We attend CME to meet persons after a very long time and also to learn something new from other departments also, not only from anatomy, other clinical subjects also. So today we entered the academic feast given by Ramaiah Medical College. I would like to thank the management and also the Department of Anatomy for arranging this session. Dr. Vasudha has already told one by one. It will be a repetition, but I cannot remember because all the topics were very nice. We learned about the importance of radial rejection. We usually when we ask the students to identify the vertebrae, they identify thoracic vertebra and cervical vertebra. That itself is a very great thing because they don't know which is across which is axis. Because the standard has gone down so much, very pathetic. But I think this area is neglected and should be given importance. And also the basic ganglia and the neurosurgical essential and the neurosurgery aspect. The last session, so many aneurysms. I never could not imagine that aneurysms can occur in so many places and so many variations can occur in cerebral vasculature and how it is so important clinically. Wonderful session, sir. I would like to thank all the consultants who have come all the way and they have shared their experience. It was really nice and we have to, as an analyst, we should also collaborate with clinicians to enrich our knowledge so that we learn and we impart this knowledge to undergraduate students. Thank you very much. Thank you, madam.
I thank all the guest speakers of today from the Department of Neurosurgery, Dr. Pratap Kumar, Dr. Yogesh Suntakesh, and Dr. Nuhu sir for giving us the wonderful sessions, and all the delegates for their active participation. Now I request all the delegates to return their feedback forms duly filled in the registration counter and join us for high tea. Thank you once again.
Just 1 second, last announcement. Bus arrangement is made 2 buses. Transport arrangement has been made 2 buses in the ground floor for advanced learning center. Those who want to visit our advanced learning center, skill lab